Can we start now? Can you start the team? Please confirm. Can you start? Please tell me. Anybody online? Anybody online? The link was new. Have you joined? Okay. We're starting now, I think. Okay. So, guys, the second part of the revision after the ear revision will be now the nose and sinuses. Do not worry about the ear video. It will be uploaded soon. The minor editing is required for that. It will be uploaded soon. Okay, fine. One second. Now, the next part is nose and sinuses, very important. Rhinophyma potato nose. Everybody focus now. Okay, everybody open up your book also and main notes and keep that. And rhinophyma potato nose, it is a visual question of the exam, and it is what? It is the hypertrophy of the sebaceous glands of the skin of the external nose, more common in males. It is hypertrophy of the sebaceous glands of the skin of the external nose, more common in male. And I hope you remember it's a type of acne rosacea. It's a type of acne rosacea. It's not a tumor, it's a type of acne rosacea. Okay. No, this is a cosmetic problem only. It's not a tumor. It's a actually type of acne rosacea. And this is a visual question. And anytime you see the irregular skin in the front of the nose, it's acne rosacea. It's rhinophyma potato nose. Okay. My different rhinophyma is potato nose. Rhinoscloma is what? Rhinoscloma is what? The woody nose. That will come in later on. Now, Cottl's test is done to check the blockage of nasal valve. My dear friend, whenever you see a picture in the exam with the two finger on the cheek lifting upward, two finger on the cheek lifting upward, that's a Cottl's test. Cottl's test is done to check the blockage of nasal valve. Cottl's test done to check the These two are visual question, my dear friends. And I want to tell you one more visual question. Any chronic ulcer on the skin of the nose, pinna or eyelid is basal cell carcinoma. Any chronic ulcer on the skin of pinna, nose, or up eyelid is basal cell carcinoma. Head and neck is a common site of BCC, basal cell carcinoma, rodent ulcer. Okay, don't overthink also, bache. The edges are inverted or everted and all that. Please don't change the answer. Don't become the neurosurgeons on the day. Please respond like MBBS doctor. Understand this, why people get what stuck up at 148, 147, 149 is not that the knowledge is less. They have to practice the art of attempting the paper, understand the pulse of paper also. Common things are asked commonly. So go for the, whenever you're nervous in the paper, when you want to think about two choices, tilt towards the common answer. But a common BCC is the common answer. Okay. Now, fine. Next one, the next one, foreign body nose. Foreign body nose is more common in school age children. Okay, school age children. Now, the whenever you see a child with foul smell from nose, is a foreign body nose question. I told you earlier also, a child with foul smell from nose is foreign body nose. question. Treatment is endoscopic removal. Endoscopic removal. Okay. Now, nasal bone fracture. Trauma has been asked very, very commonly. Trauma to the nose can lead to many situations like nasal bone fracture. Like it can be the nasal septum fracture also. Fine. So, first of all, how would I diagnose this entity? So it is nasal bone is the most commonly fractured bone of face. Everybody open up your notes. Trauma causing nasal deformity. Nasal deformity indicate that there is actually the nasal bone fracture and swelling may be there, may not be there. Plus minus swelling. Plus one is swelling. Okay. Get an X-ray done. Get an X-ray done over there. Yes. Whenever trauma case like this, an X-ray given, fracture is there. He will never show you normal X-ray over there. Please understand. Common sense is the biggest sense on the planet actually. If trauma is there, X-ray is there. It's a nasal bone fracture question. Na? And don't over dissect the question also. Your treatment is immediate close reduction before edema start using Walsham forceps. Don't waste time. Now, what is the name of forceps? PYQ, Walsham forceps. Okay. And if edema is already there, then wait for 7 days and then reduce the fracture. Then reduce the fracture. Okay, fine. Now, why? Why wait for 7 days? Why? Let edema subside. Let edema subside. Okay, am I clear? Let edema subside. If edema is already there, so without edema is immediate. With edema, answer is wait for 7 days. Okay. Now, nasal septum fracture likely question. It's a visual question. If force is from front, look at me. This is your septum. If force from front, horizontal fracture. Force from below, vertical fracture. Now, horizontal fracture. Now, this is a visual question. Beta. Horizontal fracture. I know it doesn't look horizontal, but this actually look vertical. Vertical is upright like that. Anything like oblique. Oblique is also horizontal. But I know this is oblique, it's not horizontal, but this is definitely vertical. So this was a visual question on NEET PG also. Horizontal fracture also called this is a visual question also called the Zarzaway fracture. Zarzaway fracture. And vertical is called Chevalier. Chevalier fracture. Chevalier. So force from below, look at me, force from below, vertical or Chevalier fracture. And how to remember easily? Please see V for V, beta. Chevalier has a V. Chevalier has a V. V for V is vertical. Chevalier. V. Chevalier has V. V for vertical. I told you any chronic ulcer on the skin of the face is BCC, basal cell carcinoma. Okay. Or also called rodent ulcer. Rodent ulcer. It's not ulcer, it's a malignant ulcer. Huh? A rodent ulcer. Okay. Now, design of external nose, if you remember, it upper one third is bony, lower two third cartilaginous. This was the your exam question, Beta. Look at the first page of nose and the first topic of the nose, Beta. Upper one third bony, lower two third cartilaginous. This was your exam question. It means 100 question are very, very doable question with the straight away pick from notes only. Do not worry. You read so much about the so many subject, so many things you read. Common things are also coming over there. Have faith in the system. Trust the process. Trust the source also. Just keep on revising the content properly. This question was there in 2023 that what is true about the external nasal design. Upper one third bone, yes, upper one third bone, yes, nasal bone, and lower two third cartilage. The first page on your nose first topic only gave one straightforward question. Now, then this is the ethmoid bone. Ethmoid bone is single bone between two orbits, and it contains many ethmoid air cell. And these yellow cells are what in over here they are ethmoid air cell. Ethmoid is a single bone between the body, between the orbit, ethmoid air cells. Ethmoid is a single bone between two orbits that contain lot of ethmoid air cells. And let us see over there. These are the ethmoid air cells. These are the ethmoid air cells. Okay. And now ethmoid air cell, similarly here, this arrow shows the same ethmoid air cell. Let me take the arrow over here. This is the ethmoid air cell. Okay. Now, this is the crista galli. The central projection is called crista galli. And on the both sides of the cribriform plate, and what passes through cribriform plate is the PYQ, olfactory neuron pass through cribriform plate. Now, let us do the cells of the ethmoid. So all these are what ethmoid hair cell. B for bulla, B for biggest cell, largest cell, constant and largest cell. Number two, Agarnazi. These two are constant cell, mean everybody will have these cell on the CT scan. These three are the variable cells. The one, two, three are variable. matlab, Some people have it. They are variation. B for bulla, B for biggest, B for bada. Bada, largest cell of the ethmoid is what? Bulla ethmoidalis. Largest cell. Okay. Agar nazi, A double G, aage, anterior most cell. Bulla ethmoid is found in which meatus? Middle meatus. So two questions in front of you right now. What is bulla ethmoidalis? Largest anterior ethmoidal cell. Where is bulla ethmoidalis? Middle meatus. What is agar nazi? Aage, anterior most cell of the anterior ethmoid group. ONOD cell, O for optic, N for nerve. O for optic, N for nerve, optic nerve. Okay, optic nerve. Heller cell, Heller floor, orbital floor. And concha bullosa, a cell in the middle turbinate. Whenever you see a cell in the middle turbinate, you call concha bullosa. Concha bullosa. Okay, fine. Now, let us do some clinical vignettes. Whenever they say hard external nose, nasal crusting, and bad smell, without hard external nose, it is absolutely the atrophic rhinitis. But hard external nose with crusting and bad smell is rhinostroma, woody nose. It is caused by, just look at the notes, open up rhinostroma, Klebsiella rhinoscleromatis. Anybody? Which bacteria causes the atrophic rhinitis? Klebsiella uzine. Klebsiella uzine. Because uzina is the other name of atrophic rhinitis. But rhinoscleroma, other name is woody nose. It is infection caused by Klebsiella rhinoscleromatis, also called fish bacillus, more common in North India. Yes, North India. North India. Basically, people come from Uttar Pradesh and Rajasthan. Keep seeing your notes with us. This is the PDF for the last, revision just 3-4 days before exam. Okay, result bodies and Miculis cell. Now, treatment is streptomycin and tetracycline. Biopsy shows result body and the Miculis cell, and treatment shows what? Treatment shows the treatment is the streptomycin and the tetracycline. Now, so this was the picture of rhinostroma woody nose. So biopsy shows result body, Miculis cell. Patient come from North India, Uttar Pradesh, Rajasthan. The chief complaint is crusting, foul smell, and hard external nose called woody nose. And the causative organism is Klebsiella rhinoscleromatis, the bacteria. So drug of choice is combination of tetracycline and streptomycin. Everybody now open rhinosporidiosis. Let's see the main point. This is the rhinosporidiosis picture. Irregular mass. I told you already. It is infection caused by Rhinosporidium seabrai, aquatic protozoa. Rhinosporidiosis got multiple S. Rhinosporidiosis, SSS. So this is an infection caused in seen in South India, Tamil Nadu particularly, coastal area. Patient will be having history of pond water contact. Irregular nasal mass with epistaxis in patient coming from coastal part of the South Indian state, and history of going to the pond for bathing or swimming is a case of rhinosporidiosis. Okay, and we do surgery to remove the mass. After surgery, we do give Dapsone. Rhinosporidiosis. Look at the rhinosporidiosis. Rhinosporidiosis. Can you see so many times S is coming? S, S, S is South India. This is the disease common in South India. Okay. And the D will remind me D for Dapsone. In this rhinosporidiosis, only one rhino with D, we give Dapsone. Now, next one, reddish nasal mass, smooth surface, episode in 40 to 60-year-old male is inverted papilloma or Ringet's tumor. It's a benign but locally invasive tumor arising from lateral wall of nose. Everybody open up Ringet's tumor. Everybody open up Ringet's tumor just above the mucormycosis. Just about the mucormycosis topic. Okay, just about the mucormycosis topic, just let's revise. Ringet's tumor or inverted papilloma of nose. It arises from lateral wall of nose. The tumor is more common in males 40 to 60 years of age. Now see further. The tumor grows inward, therefore it is called inverted papilloma. Now your exam PYQ, it's a benign but locally invasive tumor. Okay, and the patient will be generally male, 40 to 60 year of age, with nasal mass with epistaxis, and the mass is smooth surface. Irregular surface mass is rhinosporidiosis. Irregular surface mass is rhinosporidiosis. Okay. Now, unilateral nasal mass growing backward. This one without any bleeding is enterocoinal polyp or Killian's polyp. Killian's polyp, enteroconal polyp or Killian's polyp. So we've done the three masses here only. I purposely three masses together here, which is fine. So this is the third mass. This is what? This is enterocoinal polyp. Enteroconal polyp. Okay. Now, next one. Now, allergic thick mucin. Okay, this is additional finding for the typical NEET PG. I know thick nasal mucin with nasal polypi. Polypi mean allergy, and this thick nasal mucin is due to fungal infection, allergic fungal sinusitis. Okay, and the CT scan shows the double density shadow. Normal polypi have got the homogeneous shadow. Fungal polypi got a double density shadow. Just keep in mind. Now, this is your exam question. Next one, Pott's puffy tumor. Everybody open up. Pott's puffy tumor. Find out Pott's puffy tumor is given in the complication of the sinusitis. Okay. So, if you don't treat frontal sinusitis, it can lead to subperiosteal frontal bone abscess, and that is called Pott's puffy tumor. It's not a tumor. Very famous question. Pott's puffy tumor is Poppet. Poppet means P-O-P-T. Pott's puffy tumor is Poppet means it's making fun of you. It's not a tumor, but the name is confusing. It is actually subperiosteal frontal bone abscess. It's a complication of acute frontal sinusitis. It's a painful red forehead swelling. Now, facial trauma causing nasal deformity is a nasal bone fracture question. And which forceps is used to reduce it? Walsham forceps. Walsham forceps. Walsham. Walsham forceps are used to reduce the nasal bone fracture. Everybody's septal fracture, we did that. Which forceps is used to reduce the septal fracture is Ash forceps. ASCH. So Ash forceps are for the nasal septal fracture reduction. Walsham forceps is for the nasal bone fracture reduction. Now, trauma causing bilateral nasal blockage is septal hematoma. Trauma causing nasal deformity is nasal bone fracture. Trauma causing nasal deformity is nasal bone fracture question. Trauma causing bilateral blockage is septal hematoma question. And treatment will be what? Treatment is what? IND or aspiration plus anterior nasal packing. Incident drainage or aspiration plus anterior packing. Now, next one. Newborn baby with respiratory distress cyanosis and the condition improves on crying. Please see, cyanosis improving on crying is a clear-cut clue for choanal atresia. By different, but open up choanal atresia topic. Let's revise choanal atresia. Open up choanal atresia. It's right after lateral wall of nose. Choanal atresia. What is choana? Choana is the posterior opening of nasal cavity. Choanal atresia. Bilateral complete choanal atresia is a neonatal airway emergency. Why? Because neonates are obligatory nasal breather. Typically, it's a newborn child with respiratory distress and cyanosis right after birth, but the condition improve on crying. Blue baby turning pink on crying is an indirect clue for the choanal atresia. Question. The pediatrician is unable to pass suction catheter to the nose, okay? And if you do the cold spatula test, it's negative over there. There's no mist formation on the steel spoon over there. Immediate life-saving treatment in this patient will be put a wide bore nipple in child mouth. And this is called which technique? McGovern's technique. All of you, please look at a picture or your notes also. Put wide bore nipple in child mouth to save the child. It's called McGovern technique. Okay, fine. Now, again, child with foul smell from nose is foreign body nose. Foreign body nose. Everybody look at screen. Now, this is what? This is orbit. Of course, between the two orbit, which bone is there? That is a ethmoid bone. And what is this EB? This is bulla ethmodalis. This M is which sinus? Maxillary sinus. Okay, fine. What is the name of this turbinate? Any turbinate starting from the side of the nose is what? Inferior turbinate. Okay, fine. And this EB is bulla ethmodalis. Largest cell of the thing is bulla ethmodalis. This EB is bulla ethmoid. What is bulla ethmoid? Largest cell of the anterior ethmoid group. Okay. And this, anybody will tell me what is the white projection called? Anybody will tell me what is the white projection called in the, this is called the crista galli. I hope remember, you remember this we did just now. This was crista galli, na? This was the crista galli. This is the crista galli. Crista galli. And what is crista galli on both sides? Crista galli is what? Cribriform plate. What is this? This is what? Cribriform plate. Crista galli. Then this is what? Cribriform plate area. On the side of crystal is cribriform plate. Do not get scared and nervous in the paper. Oh, why he's asking something which is not there in my notes exactly. There will be lateral, mentions of those things. You have to walk a little bit extra on that day. Except that this is the design of the paper. Do not worry that, oh my God, I'm getting nervous in the paper. Okay. Whole paper will never come from the notes. I'm being very honest. I need not really tell you that I should not be really, professing this, read these notes or, the ENT, everything. This, you are part of my family. I'm not here to prove that, okay, like we are teaching, like, like exactly, this is the word thing. This is not a kid's paper, now. We want you to pass the paper. For that, you have to understand that paper is like this only. But don't get nervous in the paper that why did he ask it? He will ask certain thing which is literally, thinking will be required for that. Okay. Now the this cell is what? Heller cell. This arrow is what? Heller cell. Heller cell lie in the orbital floor, and this cell is concha bullosa. Just see, it's a middle turbinate. A cell in the middle turbinate is called concha bullosa. So two cells are visible in this on the CT scan. Heller cell in the orbital floor. Okay, fine. This white star is the Heller cell, and this other two arrows are there. Second arrow is what? Concha bullosa. Let me remove this arrow and concha bullosa. Fine. Now this is a lateral wall of nose. The picture, and can you see inferior turbinate, middle turbinate, superior turbinate. Every turbinate has a space below that called meatus, inferior meatus, middle meatus, superior meatus. And what is S? Anybody? What is S? What is the posterior most sinus? What is the posterior sinus? Sphenoid sinus. Sphenoid sinus. Sphenoid sinus. Okay, fine. So lateral wall of nose. Cadaver picture. Huh? Fine. Now, again, this is bulla ethmodalis. This is bulla BE. Bulla ethmodalis. And this is which turbinate? Middle turbinate. Okay. This is which area? This is UP. What is UP? Uncinate process. Bulla ethmodalis uncinate process lying in the middle meatus area. And if they ever put this white circle like that, what it will denote? Anybody? It will denote what? Denote what? Osteomeatal complex. This is a likely question. Any circle in this area like that is which complex? Osteomeatal complex area. Okay, osteomeatal complex area. Okay, fine. Now, this is the, again, this is the orbit. This is the axial CT. Okay, and this is what? This is the ethmoid bone. And the anterior most cell is called the Agarnazi cell. This is the anterior, this is the posterior of the body. Anterior most cell is the Agarnazi cell. Okay, fine. Fine. What is PE? Posterior ethmoid air cell. Okay, posterior. What is SPS? Sphenoid sinus. Okay, sphenoid is the posterior most sinus, no? So, what is the anterior most cell in the ethmoid group? Agarnazi. Anybody tell me what is this cell? This is what? A cell in the middle turbinate is called what? Concha bullosa. Imagine you saw this in first time in the exam, no worry. Mark it concha bullosa. These words will be written over there. You need not recall this word. This word will be written over there. You will just see, oh, cell in the middle turbinate. Now, there are two group of people. One will get nervous. Oh my God, I never saw this city. And now what shall I do? Other people are who will say paper is like this only. Can you tell me, are you able to accept the paper is like this only? Tell me, are you able to accept the paper will be like this only? There will be certain kind of things which will be requiring the person to really, really think that a little bit out of, like notes. So think beyond notes with it. Think beyond notes. Accept it. Believe me, तुम लोग पास होने के बहुत ही पास हो, ये बात मेरी याद रखना। और मैं, इफ यू नो मी बाय नाउ, आई नेवर से एनीथिंग जस्ट टू स्टूपिडली मोटिवेट यू गाइस। तुम लोग पास होने के बहुत ही पास हो। यू आर वेरी क्लोज टू पासिंग द पेपर। यू मे बी थिंकिंग दैट यू आर inadequately prepared for the paper. A paper having 19 subjects to be asked in the exam can never give you a feeling of completion in any of the subject. Within this feeling of incomplete preparation, there lies the perfect path to pass the examination, provided you do 200% of hard work to see the content again in the remaining 28, 29 days, and you are every day keeping one window secure for the at least 150 questions to be practiced in a systematic manner of 50 50 50 question module, giving appropriate time, not playing fastest finger first, not overthinking, not underthinking, not casual study, not over study of that question, and then attempting it. This is the link may be broken for in between. Yes. Is now okay? Now okay, please tell me. Now okay, no? Yeah. There was the internet now. Everybody, yeah. Yes. Now, structures training. Everybody open up that page of your notes. Structure training into the different part of the nose. Nasolacrimal duct open into the inferior meatus. Nasolacrimal duct open into the inferior meatus. Okay. Now, maxillary sinus, frontal sinus, and anterior port cell open into the middle meatus area. Okay. So, number one, nasal NLD into the inferior meatus. Number two, maxillary frontal anterior port into the middle meatus. Number three, posterior third ear cell open into the superior meatus. And number four, yes, sphenoids are open into sphenoethmoidal recess. Guys, I hope you remember. Everybody on the same page, this picture is there, bache. On the same page, this picture is there. Inferior turbinate, middle turbinate, superior turbinate. Any turbinate arising side of the nose inferior. This is the nasolacrimal duct opening here. Maxillary frontal anterior ethmoid open into the middle meatus, posterior ethmoid open into superior meatus, and sphenoid open into sphenoethmoidal recess. That is the standard question. Now, this is, but DCR surgery opening, dacryocystorenoscopy surgery opening is in the which meatus? Middle meatus. Middle. Everybody please see in the same page written DCR opening in the inferior meatus and nasolacrimal duct opening is in the DCR in the middle meatus, nasolacrimal duct in the inferior meatus. This is the surgical opening of DCR. Okay, everybody. Again, this is the lateral wall of nose. This is the endoscopy picture. How to differentiate the inferior from middle turbinate. Any turbinate starting with the side of the nose is the inferior turbinate. Any turbinate hanging from the top of the nose is middle turbinate. Fine. Inferior and middle turbinate, and space below that is inferior meatus, middle meatus. Now, next page. Middle meatus has very, very important question also, very commonly asked topic. Now, my different, this empty middle turbinate and this space is called middle meatus. This whole thing is what? Middle meatus. And the largest cell is bulla ethmodalis. Bulla ethmodalis, B for bulla, B for bada, biggest cell. And bulla ethmodalis is the largest cell. It lies in which meatus? Middle meatus. Bulla ethmodalis lies in which meatus? Middle meatus. It is covered by a sickle-shaped bone called UP. UP, uncinate process, UP, it's a sickle-shaped bone which partially covers the bulla ethmodalis. This is UP. This is bulla ethmodalis, everybody. Bulla is the biggest cell. It is not fully visible. Why? It is covered by a sickle-shaped bone called uncinate process. Okay. And number three, ethmoidal infundibulum. What is that? It is spaced between BE and UP. Look at me. This is bulla. This is uncinate. And bulla and uncinate are not attached to each other. There is space between the two that is called ethmoidal infundibulum. It is space between BE and UP. And finally, you need not read height seminaris. It's okay. Now let me remove it. Fine. This is just from the this was a PG, this thing, no problem. Let's not complicate ourselves. Fine. I'll remove this one. Fine. Landmarks inside the middle meters. Fine. Now, OMC, you know, is a very, very important topic. Everything about OMC should be known to you. Osteometal complex is what? You know, maxillary sinus, frontal sinus, anterior ethmoid open into middle meatus. But which part of middle meatus? Into the ethmoidal infundibulum area of the middle meatus. Put an arrow, osteometal, this one. Maxillary sinus, frontal sinus, anti-ethmoid air cell drain into ethmoidal infundibulum area of the middle meatus. This whole complex called OMC, osteometal complex. Now, I told you if they put an arrow like that on the circle like that on the CT scan, it's OMC area. This bulla, this uncinate is visible over there. Fine, OMC area. And what the key pathology to cause sinusitis is the OMC blockage. Please see your notes now. What is the main pathology to cause sinusitis is osteomeatal complex blockage. Osteomeatal complex blockage. Osteomeatal complex blockage. Okay, now everybody just see the next page. There are different type of headaches or the facial pain seen in different type of sinusitis. Everybody look at me. Daytime headache, office headache is a feature of, over this area is a feature of frontal sinusitis. Occipital vertex headache. What is vertex? Top of the skull. This headache is a feature of sphenoid sinusitis. Pain over medial canthus or bridge of the nose is what? Ethmoid sinusitis, because ethmoid is between two orbits. And cheek pain is a feature of maxillary sinusitis. Cheek pain is a feature of maxillary sinusitis. Okay, fine. Cheek pain is a feature of maxillary sinusitis. Now, so let's revise once again. Different type of headache. Number one, office headache is a feature of frontal sinusitis. Yes, P by Q. Occiput or vertex headache. Posterior headache is sphenoid sinusitis. Pain over medial canthus or bridge of nose is midline over here, ethmoid sinusitis. And pain over cheek is a feature of maxillary sinusitis. No. No. Next one is X-ray. You know, a lot of questions come on X-ray. Yes. X-ray of the sinuses, water view with open mouth. Yes, this is the very, very important topic. Let us do that properly. Revision. Everybody open up X-ray from your notes. Sinus X-ray is important. Now, X-ray PNS sinus water view is the best view for the sinuses. Look at your notes, but it is the best view for sinuses. And why sometimes you open mouth to include which sinus? Sphenoid. What is S? S over there? Sphenoid. Which sinus is most clearly visible on water view is the maxillary. What is M? Maxillary sinus is most clearly visible sinus on the water view. Now, water view shows all sinus except it shows all sinus except posterior ethmoid air cell. Except posterior ethmoid air cells. Okay, posterior ethmoid air cell. Now, when you do this X-ray with open mouth, also referred to as Pierre's view. Your water view plus open mouth is Pierre view. If Pierre view is not in the choice and the mouth is open, it's water view only. By chance the mouth is open, but you know, the Pierre view is not in the choice, then water view only. Okay, fine. Now, this is the water view. And water view is technically speaking occipitomental view. What is occipital view? Chin touching X-ray plate. My dear friend, chin touching X-ray plate is water view. Drink the water like that. Okay. And if you remember, forehead touching X-ray plate, look into the well. All of you look at me. Forehead touching X-ray plate like this is the Caldwell view. Now, these two views are for the sinuses. Okay. They are for what? Sinuses. Okay. And the lower two views are for the mastoid. X-ray mastoid, ear X-ray. I mean mastoid it doesn't. These are X-ray mastoid. Okay. Please see again. In this, what is the ear touching the X-ray plate over here, and in this one, occiput touches the X-ray plate. Okay. Schuller view, ear touching X-ray plate. Townie's view. Both these views are for X-ray mastoid. Occiput touches X-ray plate. Okay. Now, yes, please look at me. Look at me. how to differentiate water view from the cardinal view. The water view is, like marked, answer marked. Don't look at the open mouth or the closed mouth. Water view is marked as an answer when maxillary is nicely visible. And when maxillary is not nicely visible, it's cardinal. Very simple. Maxillary nicely visible is water view. Maxillary not nicely visible is actually the cardinal view. The cardinal view is better for frontal followed by ethmoid. Cardinal view is best for frontal, but yes for ethmoid also. Now cardinal view is occipitofrontal view. As I told you, forehead touching X-ray plate. Occipitofrontal view. Forehead touching X-ray plate. Okay. Now I'm sure you know this is water view, cardinal view, water view, cardinal view. Fine. Water view, cardinal. Am I clear? This is about the X-ray story over there. The X-ray story over there. Again, in the same, I'm putting this in a Telegram group. Wait here. Let me make a summary for you guys for the Telegram group. Now, everybody, summary of X-ray of sinuses and the mastoid together. There are two sinuses. No, I'll record. X-ray sinuses, two views are done, water view and cardinal view. Water view is the best view for sinuses. It shows all sinuses except the posterior ethmoid air cell. Water view shows maxillary sinus most clearly. Water view can be done with open mouth to see the sphenoid sinus. Water view plus open mouth is equal to Pierre's view. But if by chance Pierre view is not the answer, then you mark water view only. Now, the water view is technically speaking occipitomental view, means chin touching X-ray plate. The second view is cardinal view. Cardinal view is occipitofrontal view, best view for frontal followed by ethmoid sinuses. In cardinal view, forehead touches X-ray plate. So, whenever the X-ray picture is given in the exam for the sinus X-ray, first of all, rule out peer view is not there. Then the answer is either water view or cardinal view. If maxillary is nicely visible, it's water view. If maxillary is not nicely visible, it is the cardinal view. For the radiographic question, there are four views which are asked. Two for sinus, two for the X-ray mastoid also. For mastoid, there are two views, Schuller view and Downey's view. My dear friend, when chin touches X-ray plates, let us drink the water, water view. When forehead touches X-ray plate, let us look into the well, called well view. When ear touches the X-ray plate, let us sleep, sleep. As for sleep, as for Schuller view for X-ray mastoid. And when occiput touches the X-ray plate, let us walk towards the town. Townie's view for X-ray mastoid. This is X-ray sinuses summary in this group. X-ray sinuses summary. Am I clear? Understandable? Do you think it will help us in the exam? Fine. Okay, no problem. Okay, now let us go to the next one. Mucormycosis, very, very important topic. Mucormycosis, yes. Now, mucormycosis is more common in all of you open up the mucormycosis topic from your workbook. Mucormycosis topic from your workbook. It is seen in uncontrolled diabetic patient. Means HbA1c will be given high. Patient has been not taking proper treatment or diabetic ketoacidosis. HIV positive patient, immunocompromised patient, neutropenia, they might say CD4 count is very low. Okay. COVID-19 patient lead to immunosuppression. Steroid lead to again immunosuppression. Okay, fine. They might say it is a post-renal transplant patient. Paper will be having certain scope of, understanding and answering. Renal transplant patient will be requiring immunosuppressive drug, and they can be, candidate for immunosuppression also due to overdose over there. Why mucor killed so many people in Delhi during Delta strain? Mucor is angio-invasive fungus. So number one, it can grow from nose to orbit and brain. And once brain got involved, it's a life-threatening infection. Number two, when the angio invasion occur, look at your notes, it causes ischemic necrosis. When blood vessels are blocked with the fungus, ischemic necrosis, hence blackish discoloration of tissues after few days. Ischemia necrosis will not happen in one day, after few days. Now, early picture of the clinical picture is of two stages: A early, B late. Early picture is inflammatory color, which is red. Early is red color, inflammatory. And the late color will be after 2 3 days will be necrosis black. So early redness over cheek. Cheek means this one. This is maxillary sinus full of mucor. Okay, fine. Then eye swelling, diplopia, blurring of vision. And the important thing is loss of upper teeth. Look at your notes. Loss of upper teeth is written over there. Please, loss of upper teeth mean the upper teeth are attached to base of maxilla, and maxilla is full of mucor, and there is early ischemia over there. And black is what? Blackish nasal mass and blackish discoloration around the eye. In HIV positive patients, something black in or around the eye is mucormycosis question. MRI scan with contrast is done. Yes, with contrast. Don't mark without contrast. With contrast MRI. MRI should be done, but with contrast. Plain MRI don't mark answer. That's wrong. Okay, MRI with contrast, and that shows black turbinate sign. Look at your notes. Black turbinate sign are is feature of the mucormycosis on MRI scan with contrast. MRI scan with the contrast shows black turbinate sign. And where the black turbinate sign? This is your black turbinate. All of you, please review this MRI. This is the black turbinate. This is of course, the mucor filling the maxillary sinus, and that's the black turbinate sign on the contrast MRI. Okay, and if you do biopsy, biopsy, and just see, aseptate hyphae. Biopsy is the best investigation. Aseptate hyphae are feature of mucormycosis. Okay, but septate hyphae. Anybody? Septate hyphae with branching at 45 degree. What does that indicate? Branching at 40 degree. That is not, that is very good, Sunny. Aspergillosis or aspergillus. Hai. We will not be in a hurry in the known question. Because in this duration now, please keep your social interactions to the lowest level. Be quiet, be calm, and stay hopeful and stay prayerful every moment. That's how I practice also. Close to the exam, decrease the phone calls, social media. Instagram reels are strictly prohibited. Going to Snapchat is a crime right now. Why you want to go to Snapchat, by the way? Which picture you want to put on Snapchat? Enjoying biochemistry? No, na. Why you want to go to Snapchat now? So all these kind of YouTube shorts are disastrous, I'm telling you. Brain is fatigued after watching reels. It's not a time to watch YouTube shorts. No, no, Dr. Dhawan, I get little bit, less tense after watching the YouTube and all that. You can hear the audio songs, but visuals should not be given to brain. Let the brain centers be totally dedicated to recall during exam day. For that, you have to create a vacuum in your brain. Only audio songs are okay. You want to hear Tamil song, Malayalam song, Kannada song, Telugu song, Hindi song, Punjabi song avoid. You start dancing over there, na? Like that. So don't dance like that. So right and time is sublime. Punjabi song can't make you like that. Don't know if until it's like Satinder Sartaaj song might be like that, but avoid that. You can be songs which are like keep your mind little quieter like that. Fine. So in that case, like more things will be recorded. But this is time to decrease the calls you make here and there. Unnecessary calling your mother, father, I'm feeling tense. Everyone is tense. What's the big news in that? What news you want to crack to them? Don't do all those things. Huh? Just study now. You create vacuum and study. Create vacuum and study. Just focus on studying now. Believe me, once you see that after third revision and last 10 day, 7 days revision, you will be able to recall that in a better way for sure. After seeing, you'll recall that. Okay, fine. Treatment is debridement. Why? Dead tissue, na? Debridement. Dead tissue should be debrided. Ischemic dead tissue should be debrided. Number one. Number two is drug of choice, liposomal amphotericin B. I think that's the PYQ also. Liposomal amphotericin B. Is mucormycosis revised? Mucormycosis revised, everybody? Fine. Samtus tried is a very, very likely question. I'm telling you. Samtus tried. All of you look at, open your notes, Sudha, of polyp topic. Go to nasal polyp topic. Okay, fine. Samtus tried. Is it allergy? Tell me. Is it allergy? No. Is it allergy? No. Is it IG mediated? Pharma question. Immunology question. No. Not IgE mediated. Therefore, antihistaminics like cetirizine, loratadine are of no use. Are of no use to the antihistaminics are no use. Okay, fine. Antihistaminics are of no use. Okay. Then what is the problem? It is not allergy to NSAIDs. It is intolerance to NSAIDs. Basically, which group of NSAID? Look at your notes. COX-1 or COX-2 inhibitor? COX-1 inhibitor. Which is the most classical example of COX-1 inhibitor? Aspirin. But it is not only for aspirin. A pharmacology question, medicine question, ibuprofen also. Ibuprofen also. Okay, fine. Now, due to that, body produces wrong kind of prostaglandins. So, asthma is there. Asthma is not extrinsic. It is intrinsic asthma. Asthma is not extrinsic. It is intrinsic asthma because your body is producing wrong kind of prostaglandins. And number three, bilateral ethmoidal nasal polypi. Let's revise. Centus triad is number one is the intolerance to COX-1 inhibitor group of NSAIDs, particularly aspirin. The other example is ibuprofen. Number two, bronchial asthma-like feature, but the asthma is intrinsic asthma, not extrinsic. There is no allergy to pollens and all that. Body is producing wrong kind of chemicals which are causing bronchoconstriction. Number three is due to chronic inflammation, they lead to bilateral ethmoidal nasal polypi. Fine. Can Montelukast help this patient? Yes, Montelukast can help. Montelukast, leukotriene inhibitors, they can help you with that. Okay, Montelukast help, but antihistaminics will not help. Now, Kalman syndrome is what? Infertility and smell issues. Why infertility? Due to hypogonadism. And why smell issue? Due to anosmia. Due to anosmia. Okay, fine. Anosmia. Okay, fine. Fine. So, infertility due to hypogonadism and ENT problem is anosmia. Anosmia. Okay, fine. Now, so anosmia with the hypogonadism leading to infertility. The combination is called Kalman syndrome. Everybody look at look at chapter of olfaction now. A patient of anosmia can still sense ammonia because ammonia is a general irritant, not a smell, and ammonia is sensed through which nerve? Ammonia is sensed through trigeminal nerve. Ammonia is not sensed through the olfactory nerve. Ammonia is sensed through the trigeminal, fifth nerve. Ammonia is sensed through fifth nerve, trigeminal. Now, next, saddle nose deformity and septal perforation. Now, very, very common. Saddle nose is depressed nose. All of you go to the second page of your notes of nose. Second page. Please look at second page. Second page of notes. Nose topic. Saddle nose is due to trauma and septal surgery. Which surgery particularly? Anybody? Which surgery particularly? Anybody? SMR surgery. What is SMR? Submucosal resection of septum. Submucosal resection of septum. Page number 47. Yeah, that's a good idea. Just tell the page number also. 47, huh? Submucosal resection of septum. Okay, fine. Now. So, leprosy, which syphilis? But tertiary syphilis. Tertiary syphilis. Tuberculosis and lupus. Vaginal granulomatosis, WG. Please see what are symptoms of septal perforation. The question came, the patient has got whistling sound. After nasal surgery, whistling sound started. Which surgery could have been done? SMR surgery. What is SMR full form? Submucosal resection of septum. Okay. And number two, there can be crusting in the nose. Maybe bleeding also, but crusting. Whistling and crusting after surgery of the nose is indicative of septal perforation. Which surgery could have been done in the past? SMR surgery. Then the vaginal granulomatosis. Please look at the biopsy finding. Tuberculosis will show biopsy finding caseous necrosis. On biopsy, caseous necrosis and necrotizing vasculitis will be the finding of vaginal granulomatosis. Necrotizing vasculitis. Vasculitis, okay, fine. And which test we do for vaginal granulomatosis further? We do CNCA testing. CNCA testing is done for the vaginal granulomatosis. This is a very likely topic. Integration of pathology with ENT is possible in this. What is the PYQ already? SMR surgery. SMR surgery. Which surgery can lead to perforation? Submucosal resection of septum. Submucosal resection of septum. Now, next topic, maxillary sinus cancer. Cancer by sinus. Now, maxillary sinus cancer patient have got cheek anesthesia. This sensation is gone. No sensation here. Why? Due to involvement of which nerve? Infraorbital nerve. Infraorbital nerve involvement. Infraorbital nerve involvement will be there. Am I clear? Now, Ongren line. Next page. This is Ongren line, page number 62. Page number 62 in your notes, Ongren line. Ongren line is line from medial canthus. Ongren line is from medial canthus to the angle of mandible. Medial canthus to the angle of mandible. Look at my beautiful drawing. I don't know the drawing. From medial canthus to the angle of mandible. Any tumor above this line will enter the orbit very fast and will lead to poor prognosis. Due to poor prognosis, due to early orbital invasion. Due to early orbital invasion. Everybody, are you getting tense or you are still maintaining a smile on your face? It's okay. It's an exam only. Just staying like this will not increase the chance of us passing it. Okay, staying like this might make us make the right guesses in the paper. Okay, fine. This is important. Wait. Again, this. Yeah. Yeah. 1 minute. Yeah. Are you able to hear me now? Are you able to hear me, everybody? Are you able to hear me, everyone? Now, the okay, fine. Now, Nick is saying आता सब है. Let me take your question, brother. लेकिन question हो नहीं पा रहे. Nick, don't generalize. Nick, I have a question to you. कोई भी क्वेश्चन नहीं हो पा रहा. You can't do any question. Nick, I have a question to you. You are writing that question नहीं हो पा रहे. My question to you is क्या सारे क्वेश्चन नहीं हो पा रहे हैं? There are three type of like things happening in the paper. One is which question you know and you attempt it correctly. Other are silly mistake. Third are you are not able to integrate or relate to the question in when the question is little complicated. No problem. Let's say every day 150 question. Why I'm saying every day 150 question? That is mandatory, but mandatory. Why? Because paper ultimately is not subjective, objective. What is the best time to do multiple choice question in the remaining 28 days now? Whatever days are left now, what is the best time to do multiple choice question is the post lunch session from 1 p.m. to 4 p.m. Why? Because your paper 2 will be occurring at this time only. Best time to do the multiple choice question will be post lunch session starting from 1 p.m. to 4 p.m. would be the best time to do the multiple choice question, or maybe you can say 2 to 5 p.m. no problem. Exactly matching with that also 1:30 to 4:30. But 3 hour window, please keep it just like your paper 2 will be. Can we commit to each other? Can we commit to each other? We'll be doing every day paper 2 for next 28 days. Yes or no? Tell me. Can we keep a paper 2 every day for us after lunch from 1 to 4, from 2 to 5, or 1:30 to 4:30? Every day we have a paper 2 with. Why can't we really do that? There is a way to pass the paper. Paper 2 you do after lunch. There is a pressure of paper 1 which has gone plus minus, and there is a lot of mental arithmetic required for that, and lot of integration required in paper 2 also. So why can't we make custom module every day of one subject, two subject, three subject, four subject, depending on your mood or plan or which subject you're doing? No problem. If you're doing optha today, you combine optha plus orthopedics, or optha ENT orthopedics, or you can do the optha derma radiology like that. Like this is what. So every day, not randomly. Doing one question, one explanation is not a good idea. Let us attempt paper 2 every day of 50, 50, 53 modules and then review them at the end. But if you are playing fastest finger first, if you are attempting 50 question in 17 minutes, that's a problem actually. You have to take 30, 35, 40 minutes for attempting the whole paper of 50. Otherwise, you are not actually doing justice to that. Always keep the difficulty level moderate. Don't keep it easy for yourself. Don't do just PYQ based custom module. Always include the NEET PG question also. Always include a little, like general questions also and all those things. But difficulty level should be kept moderate over there. And there lies the whole practice of paper two, which is at your disposal. You can do that. And once you do that for consecutive next 28 days, on the real exam 17th January, when you go over there, your brain has been primed for last more than 3 weeks that every time at 1 p.m. or 1:30 p.m. you are actually into the very active, span of the brain activity. Lot of activity of brain occur at that, and now brain got you. Brain is nothing but anything done repeatedly become a habit. Anything done repeatedly become a habit for the brain, and brain is more pepped up to do like that actually. Fine. Why can't we train our brain for paper two right from now till the exam day? Okay. बट सोचने से नहीं होगा, करने से होगा. मेरे बोलने से नहीं होगा, तुम्हारे करने से होगा. है ना? Fine. So please implement, things also and see what difference they can bring over there. Now, next one. Now, this is the surgery. This patient will need which surgery? Look at your notes. Total maxillectomy. Remember last time picture also came with a total maxillectomy surgery by which incision? By Weber Ferguson incision. Yes. So this specimen is what? Weber Ferguson incision patient. The picture is of that. Fine. So Ongren line, total maxillectomy, Weber Ferguson incision. Okay, fine. All these are done. Now, next topic. See, everybody open up CSR Enoria. Tell me the page number. Tell me page number CSR Enoria. We are making a PDF for the final revision. I have actually made this PDF for the final revision of your paper so that you don't waste time. Actually, this is the reason why this is the first time I create a PDF. Let me tell you, Keval, everybody hear me. Keval Himanshu, this is the first time I have made this PDF. Honestly, I never made PDF because I thought that the main notes are good, but I thought like we can have one quick reference thing for in 1.5 2 hours in the last. This first time I create a PDF like that. Otherwise, I've never made PDFs actually like that. Okay, fine. Now, CSF rhinorrhea. Now, CSF rhinorrhea, causes, most common causes fast surgery. Surgery, which surgery? Fast surgery. Now, fast surgery, which plate got injured? Cribriform plate. Now, this is the MCQ expected. After FAS, if after FAS surgery, functional endoscopic sinus surgery, or a trauma to the skull head injury, any fluid leak from nose fluid coming is CSF. Okay, fine. Yes, the Himanshu actually I done it only because Anuradha, my wife, she has made Optha PDF, so she has been like telling me you can also do that, so that's why I did that. To be very honest, yes, she's the one who gave me this idea. We were talking and she said that we hardly talk about the subjects and those kind of thing. We don't talk like this for stuff, but generally we're talking and I said, What do you do?" She said, "I do this." So you can also try. That's why I tried it. To be very honest, she was the inspirational source behind it actually. Yeah. Now, so after FES or trauma, nose fluid is CSF. So, which plate could have been injured? Cribriform plate. Okay, cribriform plate is a part of F1. Now, number two, head injury. Very, very famous question. And which bone fracture? Ethmoid bone fracture. Everybody look at the page number. I think somebody wrote the page number 84, I guess. I don't know. Okay. PDF will be sent to you. PDF will be sent to you. This same PDF will be sent to you by the team actually. I've told them already. ethmoid bone fracture. Once I'm finished, I will send it to you. Don't worry. And this is called target sign, hello sign, or double hello sign. Page number 71 in the original complete double hello sign. Dr. Dhawan, is there a double target sign? No. There's no double target sign, bro. Double hello sign, target sign. But by chance they say double target sign because Dhingra at one place has mentioned double target sign also. But in the reference books, actually, the word is hello sign, double hello sign, and the target sign. But by chance there is a word of double target sign, then okay, fine. Fine. So that can be on filter paper. Why? Because the traumatic leak are blood mix CSF. So this is for only for traumatic. Just look at your notes written there. Traumatic CSF leak has got target sign. Not all leaks, not all leaks. Okay, fine. And what is this showing over there? This is showing what? Look at your notes also. It is showing what? Cribriform plate, which is a part of which bone? Ethmoid bone. So this is cribriform plate is a part of ethmoid bone over there. This is cribriform plate in your notes. The brain tumor leaks and the spontaneous leaks are clear CSF. In that, we don't see the target size. Target size, very famous visual question. It can come. Overall, most common site I already told you is the cribriform plate. It is a part of the ethmoid bone. So this is the cribriform plate in your this PDF also. How would you confirm diagnosis? PYQ. Handkerchief test, CSF is non-sticky. Patient cannot sniff back CSF, biochemical analysis. But the most confirmatory test is beta 2 transferrin estimation. Look at your notes. Beta 2 transferrin is the test to prove the CSF. Beta 2 transferrin estimation. Test to find the site of leak. Now, best radiology, number one. Best radiology investigation is number one, HRCT skull base. Number two, in MRI, if you know MRI, not T1, T2. T2 is good for the CSF. Okay, fine. Number three, CT, cystoscopy invasive test. And number four, nasal endoscopy with intrathecal fluorescent dye injection. And fluorescent dye will give green color to CSF. Green color to CSF. Okay. Now, treatment, don't write urgent surgery. I told you in CSF rhinorrhea, no urgent surgery required. Admit the patient and treatment is conservative with bed rest, antibiotic. Bed rest and also cough suppressant. You know, cough increases CSF pressure. Now, maybe cough suppressant is not in your notes, but do you know? Do you know cough increases CSF pressure? Do you know cough increases CSF pressure? Why we are giving laxatives to this patient? Because even constipation, passing a constipated stool can lead to increased CSF pressure. So they all bed rest, cough suppression, laxatives, all these things do what? They keep the CSF pressure low. And why you give antibiotics? To prevent meningitis. Antibiotic why? So that meningitis not happen. I have question Abhi, Keval, Ananya, everyone to you guys. By chance, you've never read the word, like your notes do not have the cough suppressant. I know that word is not there. But in the exam, by chance, this is there. One of the following is not a treatment for the CSF rhinorrhea, bed rest, like cough suppressants and all that. Can you extend your thinking process to this level? Yes, cough will increase CSF pressure. I've heard that in medicine or in pediatrics, that coughing, crying increase the CSF pressure. I think giving CSF, I think giving cough suppression will keep the CSF pressure low. Maybe it is helpful in this also, and I will apply my common sense over there. Or you will go that no, it's not written in my notes, and my notes are the final Bible on the subject, and I would not really think at all. Tell me, are you able to relate to this flow of the paper? Are you able to relate to flow of the paper? हमें लकीर के फकीर नहीं बनना है. Don't go to the exam with the burden of the words of your notebooks. Go to the exam with the light of knowledge of the 19 subjects which you acquired, and play just with the common sense and go for the common things over there. Okay, fine. Understandable, no? Yes, very good logic. Ananya, that's very nice. Ananya said logic lag jayega. This is what, na, na? Fine. Now, we have come to the blood supply of nose. Everybody go to the next page of blood supply. CSF leak after the blood supply. Now, ECA has got 80%. Yes, ECA got 80%. आज लिख लेना कि डॉक्टर धवन ने ये बात बोली है, हम पास होने के बहुत ही पास हैं. We are very close to passing the paper with the blessing of our parents and Almighty. And if we do a lot of hard work in the remaining 28, 29 days, we do as much content as possible revision. We do 150 questions every day in the one day. We review from mistakes. We don't get discouraged from the GT score of 138, 163, 159, 148. No, we learn from mistakes and we keep the hope of passing alive within us till the last second of the exam is over. Let us keep the hope of passing alive within us from this moment to the last second of the exam on 27th January, very well knowing that there is nobody on the planet who knows everything about everything in medical science. Accepting that I do not know everything about everything in the all 19 subjects, but I think I know sufficient enough to pass the examination in a comfortable manner with a good score. This is possible. Okay, fine. Now, blood supply of the nose. Blood supply of the nose come from two systems, ECA, ICA. Now, up to middle turbinate. Up to middle, all of you look at your notes. Now, up to middle turbinate is external carotid artery, and above that is internal carotid artery. This is 20%, 80%. Now, ECA gives three branches. All of you look at your notes. You know, sphenopalatine, greater palatine, and superior labial. Superior labial artery. IC give two branches, anterior model and posterior model artery. I hope you remember which artery is called artery of epistaxis. Which artery is called artery of epistaxis? Artery of epistaxis is sphenopalatine artery. Sphenopalatine artery, है ना? The little area is the commonest source of bleeding. It lies on the antero-inferior part of septum, on the beginning of septum. If this is your septum, it lies on the antero-inferior part of your septum. Is which area? Little area. It contains a plexus called Chiasal plexus, and Chiasal plexus is having four arteries. MCQ, you know, sphenopalatine plus greater palatine plus superior labial plus anterior ethmoidal. Which artery is not a part of plexus? Look at your notes. Posterior ethmoidal artery is not a part of this plexus. Now, everybody, do not forget Trotter's method. All of you open up your notes and just read the first aid of that Trotter's method. What is Trotter's method? It is the basic first aid for the epistaxis management. And just keep in mind that patient has to do what? Patient has to, sit down, bend forward, and pinch the nose, breathe through the mouth. Okay, I'm going to put the picture in your this thing also. This may be the new question. This is which picture? This is the Trotter's method picture. Trotter's method is what? Sit down, don't lie down. It pinch the nose and breathe through the mouth, and whatever comes to throat, spit it out. Trotter's method is to control the breathing. Fine. Now, question number one. Packings failed. If packing fail, all of you, if anterior posterior packing failed to control bleeding, then what is the next surgery we do? Endoscopic sphenopalatine artery ligation. Which artery is called artery epistaxis, sphenopalatine artery? If they ever give you this question that bleeding could not be controlled with the packing, it is endoscopic sphenopalatine artery ligation. Okay, E-spell. E-spell. Okay, fine. E-spell. Yes. They can say, now please see. On the exam, they won't say E-spell. You know what they say? They'll say T-spell. And you will say, oh my God, Dr. Dhawan did not make us write T-spell. T is what? Brother? Transnasal endoscopic sphenopalatine artery ligation. Tell me, tell me, I have a question. My notes have this. Paper is this. Please see This is the thing. My notes have this, but paper is this. Will you mind it or will you process it? Will you mind it or will you process it like just transnasal or not transnasal? Will it, like it's okay. You're like that, nah? It's okay. It happens, like that. Transnasal, endoscopic, the same thing now. Now, the second question, if ECL ligation failed to control bleeding, then next artery is ethmoidal artery ligation. Now, ethmoidal artery is a branch of ICA. I can't tie the I can't tie the ICA, but I can ligate the branches of the ICA. Okay, ethmoidal artery ligation. Ethmoidal artery ligation. Okay, fine. Now, so all the question go with the, and one thing is more, if packings are not, if packing is kept more than 48 hour, what syndrome can develop? Packing kept for more than 48 hour, it can lead to toxic shock syndrome. If you don't remove the pack in 48 hour, toxic shock and syndrome is which bacterial colonization? Staph aureus. Staph aureus. Staph aureus. Okay, Staph aureus. Okay. Now, rhinitis medicamentosa, next topic, rhinitis medicamentosa, it is due to prolonged use of decongestant nasal drop. Rhinitis medicamentosa. If someone is putting the Otrivin drop for a month, 1 month, he can develop a rhinitis medicamentosa, and this is due to rebound congestion. Look at the treatment and tell me what is the treatment of rhinitis medicamentosa. Stopping the drop is not solution. The treatment is page number 64. Yes, page number 64. You start steroid spray. You start a steroid spray. Why? Steroid will lead to shrinkage of the tumor. Steroid will lead to shrinkage of the tumor. Shrinkage of tumor. Okay. Now, prolonged use of decongestant drop is the first line to remember. Prolonged, not the overuse. The keyword is for more number of days. And start steroid spray. Why? To shrink the turbinates. Treatment is what? To shrink the turbinates. To shrink the turbinates. Now, I think three nasal masses we have already done. One is without bleeding. Okay, without bleeding is AC polyp. Okay, and other is what? The Tamil Nadu story, pond story, Tamil Nadu story, pond story is rhinosporidosis. Fine. Now, everybody, let me quickly revise with you atrophic rhinitis also, Bache. Everybody open up atrophic rhinitis. Atrophic rhinitis, everyone open. Atrophic rhinitis. Which page number? Atrophic rhinitis, please open up. Atrophic rhinitis is important. We done atrophic rhinitis, ozena. What is the name of the bacteria? Klebsiella, 69 page, brother. Klebsiella ozene. Klebsiella ozene is the culprit, male and female. And the two things are what? Crusting and foul smell. Patient has bad smell, but patient has which anosmia? Merciful anosmia. Have you seen merciful anosmia? Bad smell from patient, but patient cannot smell the bad smell. Merciful anosmia. What are three component of alkaline nasal douching powder? Sodium bicarbonate, sodium biborate, and sodium chloride. Okay, sodium chloride is the powder which you use to make a solution to wash your nose. And what surgery we do? The name of surgery is modified Young's operation. Modified Young's operation. Everybody look at a picture. Modified Young operation was permanent partial closure of both nostrils. Everybody look at a picture of your notes. Modified Young operation is permanent partial closure of both nostrils. Can you see the needle being shown in the front end of the nose? Modified Young operation were permanent partial closure of both nostrils. Guys, please do remind me if I left any topic. Everybody skip, please flip up this thing. Any major thing, major, minor maybe any rhinosporidiosis, rhinoscleroma. We have done the atrophic rhinitis. We have done the CSF rhinorrhea. Question of epistaxis. We have done the saddle nose deformity, septal hematoma, septal perforation. Nasal septum fracture. Then we have done the lateral wall anatomy, ethmoidal cell. All okay. Yes, DNS. Thank you for reminding me. Very good, beta. Very good. Very good. Thank you. Yes. DNS. One question. Everybody go to DNS page number. Tell me page number, bache. DNS can lead to sudden neuralgia. Everybody go to tell me page number. Very good. It's a collective revision. Dr. Dhawan also has paper. Now we're revising collectively. Very nice. Okay, DNS is the middle turbinate pressing motor, है ना? And this lead to headache, and that headache is called sudden neuralgia. Why DNS can lead to headache? Because the DNS pressing the middle turbinate, it's also called sudden neuralgia or anterior ethmoidal neuralgia. Everybody go to the next page of this and see what is the most common long-term complication of nasal surgery. Most common long-term complication of nasal surgery. Everybody, what is the answer written on next page? But next page, most common long-term complication of nasal surgery is Senneke formation. Nasal surgery, Senneke adhesion formation. Anybody, which drug can be applied to prevent it? Drug can be applied? What is the answer? Senneke adhesion formation. Senneke. And which drug can be applied to prevent it? Mitomycin C. Mitomycin C is used to prevent the Senneke formation. Mitomycin C is used to prevent the Senneke formation. Everybody okay? Now tell me anything else. All of you flip the pages, we'll revise that also. All of you see the pages, tell me anything left. With an osteometal complex, bullous modalis, agonadi cell, with a CT scan, X-ray sinuses revision. We've done the Pott's puffy tumor. It's not a tumor, it's a frontal bone abscess. Ringet's tumor, rarely a tumor, benign locally invasive tumor. We've done the cancer patient. All okay? All okay, Anya, Cable. Everybody okay? Now, let us have a quick recap of pharynx now. Everybody, can we start now, Vijay? Can we start, everybody? Pharynx. All okay? Fine. So, now, okay, Anya? Fine. So, let us start, Abhi, everybody. Now, pharynx, please open up your pharynx. First page, everybody go to pharynx. Now, there are three parts of pharynx. We know that. Nasopharynx, oropharynx, laryngopharynx. First of all, laryngopharynx, also called hypopharynx. Leaf foot fracture you can see over there. Leaf foot fracture, not leaf foot fracture, the important thing is CSF rhinorrhea. Traumatic CSF leak. Anybody getting head injury after that fluid coming from nose is CSF rhinorrhea. Okay, chalo. So pharynx is 31 page, I guess. Okay. So laryngopharynx or hypopharynx, everybody, piriform sinus right and left. Three parts are there. This is piriform sinus right and piriform sinus left. Any arrow on the side of larynx is piriform sinus. Okay. Postcricoid area is behind the larynx and posterior pharyngeal wall. This is PCA. What is PCA? Postcricoid area. This one. And this mucosa is called PPW. What is PPW? Posterior pharyngeal wall. So look at your notes. Look at notes. Larynx has pressed the laryngopharynx. Larynx has pressed the laryngopharynx against the vertebra. Okay, fine. This is laryngopharynx. And I'm sure you know PS on both sides. This is what your food channel. Piriform sinus, postcricoid area. And the mucosa is called PPW. Now, this is a visual question of your paper. Now, am I clear? Fine. Now, everybody, just to the next page. Next page over there. Internal laryngeal nerve. ILN. Internal laryngeal nerve is the other name of internal branch of sphenolaryngeal nerve. It gives sensory supply to piriform sinus and the supraglottic region of the larynx. So this is a famous question of your exam. When the fishbone got stuck, and fishbone was removed and surgeon injured the internal laryngeal nerve, where was the fishbone stuck? Piriform sinus. So what is the sensory nerve supply of particular sinus? Answer is internal laryngeal nerve. Internal laryngeal nerve. Everybody at the same page, you just divide laryngeal crepitus. When you move the larynx like this, larynx, there is a clicking sensation felt. Look, all of you revise laryngeal crepitus. It's a clicking sensation felt when larynx is moved over cervical vertebra. This crepitus can be absent in number one is post-cricoid carcinoma. Number two, read your note, post-cricoid carcinoma. Number two is the retropharyngeal abscess. Number three, prevertebral abscess. Number four, fracture of thyroid cartilage. And in these four conditions, it will be absent. Don't forget post-cricoid carcinoma. This crepitus is absent. Absence of laryngeal crepitus is called the Moore's sign. Moure. Absence of laryngeal crepitus is called Moore's sign. Moure. Moore's sign. Moure. Absence of laryngeal crepitus is called Moore's sign. Moure. Moure. Everybody, now let us start the nasopharynx. Everybody, let us start the nasopharynx. Can you start nasopharynx? Okay, now this is your nasopharynx. This is your nasopharynx. Huh? Fine. Now, please see. All of you open up your notes and revise the nasopharynx picture with me. This is the cadaveric picture of nasopharynx. Let us label this picture and revise the picture. Of course, this is eustachian tube opening of this side and eustachian opening of this side. And my dear friend, this bulge around the ET opening is called torus tuberous. What is torus tuberous? Torus tuberous is the bulge around the ET opening. Keep revising torus tuberous, this one. Now, torus tuberous contains some lymphoid deposits. What are these lymphoid deposits called? Tubal tonsil. Tubal tonsil make the torus tuberous. And this space above the opening is called the fossa of Rosenmuller. Fossa of Rosenmuller. This is the cadaveric picture of the nasopharyngeal area. This is the nasopharynx. So nasopharynx, normal anatomy. Normal anatomy. Now, let's revise the main points of adenoid. Everybody open up adenoids. Revise with me adenoid. Now, for all of you, look at your notes. Now, adenoid, all of you please revise as I say. Adenoid is a collection of lymphoid tissue in nasopharynx. Adenoid has no capsule, no crypt, no definite blood supply. Adenoid are prominent in children. Adenoid disappear by 20 years of age. Now, next line, please see. Adenoid hypertrophy is a disease of school age children. More than usual enlargement of the adenoid is called hypertrophy. And the typical look of the baby is called adenoid face. It's called adenoid face. Fine. Adenoid face and mouth open. Okay. History of mouth breathing, open mouth, crowding of teeth. Something about dental alignment will be malocclusion of teeth, crowding of teeth, high palate. Something about dentition will be written over there. Along with that, please see now the type of voice in adenoid hypertrophy. The type of voice in adenoid hypertrophy is what? Rhinolalia clausa. Everybody, what a type of voice is what? Rhinolalia clausa. What is the name of voice of adenoid baby? Rhinolalia clausa. Rhinolalia clausa means dull voice. Clausa is equal to dull voice. Rhinolalia clausa, why? Nose closed. Nose is closed, therefore voice is rhinolalia clausa or dull voice. Dull voice over there. Okay, fine. Now, patient will be having glue ear, mostly bilateral. Generally, mouth breathing child with hearing loss, both sides. Adenoid hypertrophy is glue ear feature. Okay, mostly bilateral. And the surgery is adenodectomy. What is the best method of adenodectomy? Coblation. Coblation, this is the coblation, the best method. Okay, guys, this is a normal picture of the adenoid. This is adenoid hypertrophy. This is normal adenoid versus adenoid hypertrophy. That's why child mouth is open. Everybody, what is the position of patient during surgery? Position of patient during surgery is rose position, neck extension. But don't extend the neck too much. It can lead to atlantoaxial subluxation, C1, C2 subluxation. And this is called Grisel syndrome. GRISL, Grisel. And what would you do in this case? What we do in this case is what? The symptom will be torticollis or neck spasm. The neck pain, neck spasm after surgery, torticollis, and treat and advise MRI. MRI will be required for that. And what is the name of the position? This position called Rose position. Rose position is about the neck extension. Rose position is about the neck extension, and it's the same position used for tonsillectomy also. Okay, tonsillectomy also. Am I clear? Everybody, are you able to revise now? Everybody, the adenoidectomy, the conventional surgery was curettage, but not a good method. The newer technique, look at the last part. Newer technique are what? The coblation, suction diathermy, microdebrider. These three are endoscopic surgeries. So less chance of bleeding and less chance of complication. But out of these three also, what is the best method of the surgery? Coblation is the best method. Coblation is the best method of surgery. Coblation is the best method of surgery. Everybody, can you answer this question? Can you answer the question? The if patient has got neck spasm after the adenoidectomy, tonsillectomy surgery, what would you get done? Answer is will be what? MRI neck. Why? To rule out Grisel syndrome, atlanto-axial subluxation. Do you remember when we said that? Grisel. When you over grease something, gristle. When you over grease something, it slips. Now, all of you open angiofibroma now. All of you open angiofibroma. The complete name is the juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma. Now, look at the name. It's the most common benign tumor of nasopharynx. Next line, it arises from sphenopalatine foramen. Why that angiofibroma bleeds so much? It is a highly vascular tumor. Please see, blood vessel of this tumor do not have muscular layer. No muscular PYQ, no muscular layer in blood vessels of this tumor. Therefore, they do not contract or retract after injury. Therefore, there is a chance of recurrent perfuse epistaxis. Recurrent perfuse epistaxis. Tumor is typically seen in young boys, 12 to 18 years. Biopsy is contraindicated. It's a highly vascular tumor. That's why the tumor can go from nasopharynx to nose, to cheek, to orbit and brain. The orbital part will lead to proptosis. The orbital part, look at orbital part will lead to proptosis. It's a benign, locally invasive tumor, and it can go to eye, and that's called frog face deformity. The proptosis, eye coming out, the appearance called frog face deformity, and the cheek swelling can also be there. Cheek swelling can also be there because why? Tumor can go into the cheek region as well. Cheek swelling can be there. Now, the typical triad of this patient will be a young boy, nasal mass, bleeding. Young boy, nasal mass, bleeding. Don't change answer, angiofibroma. So clinical picture is very simple. Young boy, nasal mass, perfuse epistaxis is definitely angiofibroma question. Okay, fine. Now, everybody please see the patient would be having the other symptom also. Which other symptom? Nasal obstruction, cheek swelling, dull voice, and so many other things also. So many other cheek swelling, dull voice, plus minus conductive hearing loss also, plus minus visual disturbance also. No? Because eye is also involved. No? My notes don't have visual disturbance, but my skull has brain. Check your skull. Shake your skull one time. Check brain is there or kidney is there, beta. In the skull, brain is there or kidney is there? Na? Kidney. Okay. Proptosis is there. Visual disturbance can be there. Headache can be there. Why headaches are? Brain can be involved. Whenever dura get involved, the headache is there. This kind of extrapolation of thought process is a mandatory, thing required to get the question correct over there. After 100 questions, a lot of questions will ask you to think like that, but you start feeling, I'm guessing the answer. I don't know the exact information. My dear friend, it is not chemistry. It's not bryophyte, pteridophyte, gymnos. Mangifera indica will be Mangifera indica. Musca domestica will be Musca domestica only, na. But human body is not like that. Human body has got a lot of things possible in one disease. One patient come early, one patient come late. So symptom may vary, but the characteristic symptom would be definitely given over there. Characteristic young boy nasal mass bleeding will be there. Okay, fine. Now the CCT shows what? Contrast enhanced CT shows what is Hallman-Miller sign. Your exam question, all of let's revise. Tumor is pushing the posterior wall of maxilla forward. What is M? M is maxilla. Look at the red line. Red line is tumor. Tumor is pushing the posterior wall of maxilla forward. It's called Hallman-Miller sign. Hallman-Miller sign. Okay, fine. Angiography required? Yes. Treatment is surgery. Biopsy is contraindicated. PYQ. Everybody, can you tell me which two staging systems are written in your books? Which two staging systems are written in your book? The two staging system are what? The two staging systems are what? The Fish and Redkowski staging. Fish and Redkowski staging. Everybody revise angiofibroma one time with me. Everybody go back and revise angiofibroma one time with me. Now, all of you, angiofibroma, the complete name is, all of you go to the page number. Tell me the page number. Tell me the page number. Angiofibroma, tell me the page number. Angiofibroma, also called page number. Angiofibroma, also called juvenile nasopharyngeal angiofibroma, is the most common benign tumor of nasopharynx. Page number 35, most common benign tumor of nasopharynx arises from sphenopalatine foramen. It's a highly vascular tumor made of blood vessels, and blood vessels of this tumor do not have muscular layer. So once cut, they cannot retract or contract. Therefore, there is a history of recurrent perfuse epistaxis is the PYQ. Tumor is typically seen in young adolescent male, 12 to 18 years. Okay, and the tumor is benign but locally invasive. It can go from nasopharynx to nose to cheek to orbit and brain. The orbital part will lead to proptosis, that is called frog face deformity. Patient will typically have 12 to 18 year of male patient with nasal mass with recurrent perfuse epistaxis, plus minus conductive loss, dull voice, like cheek swelling can be there. Now, we don't do CT, but we do CCT, and that shows Hallman-Miller sign or antral sign. But the other name of sign, Hallman sign, antral sign, it is the anterior bowing or posterior wall of maxilla. Okay. We do angiography, but biopsy is contraindicated. Treatment is surgery. The two staging system used over there, Fish and Redkowski staging. Now, next one, NPC, nasopharyngeal carcinoma. Everybody open up now, next topic, nasopharyngeal carcinoma. NPC. It's more common in China and Northeast India. In India, Northeast India, resident of Nagaland, Mizoram. The virus culprit is nasal Epstein-Barr virus plus genetics also. Age distribution is 40 to 70 years. Please see the notes, 40 to 70 years. Site of origin is fossa of Rosenmuller, and this is a PIQ. This is the fossa of Rosenmuller. Any arrow above the ET opening is fossa of Rosenmuller, FOR. Any opening above the ET opening, any arrow above the ET opening is fossa of Rosenmuller. This is a visual question of the paper also. Now, my defend, soon it will cause ET blockage also. Okay, fine. So it's a hidden cancer, occult primary. Please see, look at the notes. The picture is there in your notes also. This is a hidden cancer behind the nose. Very soon it will metastasize to neck nodes. So the most common presentation of NPC is metastatic cervical lymphadenopathy. Metastatic cervical lymphadenopathy is the most common clinical presentation of NPC. Okay. Now, number one is metastatic cervical lymphadenopathy. Number two is unilateral glue ear or unilateral conductive hearing loss is number two. And look at the note for the number three. When you go to the brain side, it shows which triad? Trotus triad. What is the name of triad? Trotus triad. Look at your notes. The topmost line on this on your note, the topmost line on the yellow color. Can you see that? Am I recalling correctly on this page? On the top of the your workbook, latest workbook, can you see something highlighted in yellow? Yellow. That is a very likely question. 40 to 70-year adult with unilateral glue ear is a suspicious case of nasopharyngeal carcinoma. In that case, I will not go for grommet insertion. What test I do? I written over there nasopharyngoscopy and biopsy. Nasopharyngoscopy and biopsy. It's a hidden cancer, na? Hidden cancer. Fine. So NPC presents as, look at the note, with 40 to 60 years of age with the unilateral glue ear. Let's revise. Let's revise the trotastride. What is trotastride? Mnemonic is NPC. N for neuralgia in temporoparietal area due to fifth nerve involvement. P for palatal palsy due to tenth nerve involvement. And C for conductive hearing loss due to glue. Okay, fine. Fine. C for conductive hearing loss due to glue. C for conductive hearing loss due to glue ear. Once again, N for neuralgia due to the fifth nerve involvement in the temporoparietal region. P for palatal palsy due to tenth nerve involvement. C for conductive hearing loss due to glue ear. All of them are unilateral, unilateral, unilateral. NPC is a radiosensitive cancer. So best treatment is chemoradiation. By chance chemoradiation not the choice, then you mark radiotherapy. Now, once again, let's revise NPC. So what is summary over there? More common in China, Northeast India, and the virus culprit is Epstein-Barr virus. Site of origin is fossa Rosenmuller, and this fossa is just above the ET opening, and patient is generally 40 to 70 year age. So patient develop unilateral glue ear due to unilateral ET blockage, but it's a known fact that it's a hidden cancer or occult primary. So the most common presentation of NPC is metastatic cervical lymph nodopathy or secondary neck node. And in this case, we see a triad called Trotter's triad. And the mnemonic is NPC. N for neuralgia in temporoparietal area due to fifth nerve involvement. P for parietal palsy due to tenth nerve involvement. And C for conductive hearing loss due to glue ear. NPC is a radiosensitive cancer. So after nasopharyngoscopy and biopsy, prove the diagnosis and treatment is chemoradiation. And that not a choice, then you mark for radiotherapy. Now, Stylgia or Eagle syndrome. All of you go to the tonsil area now. Tonsil, tonsil first is, please see oropharynx, various part. Just see vallicula there. Vallicula is a part of oropharynx. Vallicula is a part of oropharynx. What is vallicula? Space between base of tongue and epiglottis. Now let's move forward. Let's see you there. In the bed of tonsil, we have got styloid process and glossopharyngeal nerve. And Eagle syndrome or stylgia is what? Long styloid process touching the ninth nerve. Long styloid process touching ninth nerve, it lead to throat pain referred to ear. Long styloid process touching ninth nerve. Long styloid process touching ninth nerve, it lead to throat pain referred to ear. Okay, fine. Long styloid process touching ninth nerve lead to throat pain referred to ear. Now, next tonsil. Tonsil is lined by which epithelium? Everybody revise. Tonsil lined by palatine tonsil. Tonsil, the complete name is palatine tonsil lined by which epithelium? Non-keratinizing stratified squamous epithelium. Non-keratinizing stratified squamous epithelium. Non-keratinizing stratified squamous epithelium. Now, the main blood flow tonsil comes from tonsillar branch of facial artery, and the main venous drainage is paratonsillar vein. Venous drainage is paratonsillar vein. Okay, paratonsillar vein. Main venous drainage is paratonsillar vein and a source of bleeding during tonsillectomy. Source of bleeding during tonsillectomy. Let's revise once again. Tonsil, the complete name is palatine tonsil. Basically, it has capsule, it has crypt, and it has definite blood supply. The deepest crypt is called the crypta magna. Can you see your notes? Adenoid has no capsule, no crypt, no definite blood supply. Tonsil has capsule, tonsil has crypt, and tonsil has definite blood supply. Now, tonsil is lined by which epithelium? Non-keratinizing stratified squamous epithelium. What is the main blood source of tonsil? Tonsillar branch of facial artery. What the main venous drainage of tonsil is? Paratonsillar vein, and this is a source of bleeding during tonsillectomy. Now look at the notes. The hemorrhage tonsillectomy is most common method is dissection and snare method. Dissection and snare method. Very good method. Very, very commonly used method. Dissection and snare. I hope you remember. We dissect the tonsil and we cut the pedicle with the wire called snare wire. There are three types of hemorrhage in the tonsillectomy and MCQ. Primary hemorrhage is in the operation theater during surgery. The source of primary hemorrhage is paratonsillar vein. Number two, reactionary hemorrhage, very famous question. It is the post-operative ward in the first 24 hours after surgery. Due to slippage of ligature, it's severe bleeding. Treatment is urgent re-exploration, RE reactionary, RE re-explore. Why? The patient might die of shock or the child might aspiration of blood and die. Aspiration of blood also is a possibility. Aspiration of blood is also a possibility. Fine. What is your role as an intern? Your role as an intern is start IV fluid, arrange blood transfusion, keep the patient ready for the surgery. So basically, the stitch came out, and that actually led to a lot of bleeding. Reaction hemorrhage is severe. It is very serious emergency in the ENT practice. So treatment is re-exploration urgently in the operation theater under general anesthesia. Now, third one is secondary hemorrhage is a home. Patient went home and it occurs generally late. Late. How late? 1 to 2 weeks after surgery. 1 to 2 weeks after surgery. It is due to infection of tonsillar fossa. Due to infection of tonsillar fossa. Why? Am I visible now? All okay. Tell me confirm, please. Confirm, please. Are you able to see me now? Okay. Okay. So, So I was telling the patient was given chips to the mother gave chips to the child next day of surgery, or the solid food next day of surgery was given, and that led to infection of tonsillar fossa, but it is mild bleeding. So patient will be giving after 5 days, 6 days, 7 days, or 1 week after surgery, and then like there will be mild bleeding over there. Okay, now the treatment is admission and IV antibiotics. So let's revise once again. Primary hemorrhage during surgery in the operation theater. The reactionary hemorrhage is in the ward in first 24 hours, causes slippage of ligature. It is severe bleeding. Patient is about to die. Patient might aspirate the blood and die. Patient can run into hemorrhagic shock. So my role is to come back to the hospital and do the urgent re-exploration in the operation theater under general anesthesia. And your role is to save the patient till the time I come. Your role is to start IV fluid and arrange blood transfusion. Secondary hemorrhage is a late hemorrhage, delayed hemorrhage. It's after 5 days, 1 week, 2 week of surgery. The story will be mother gave chips to the child or rice to the child next to surgery, and that led to infection of tonsillar fossa, and that's a mild bleeding. Admit the patient again and start IV antibiotic plus semi-solid diet for few days. Yes, plus a semi-solid diet for few days. Semi-solid diet for few days. Semi-solid diet for few days. I have a question to all of you, Vijay. I have a question to all of you. All of you have to attempt this question and tell me. What is the best method of tonsillectomy? What is the best method of tonsillectomy in a child suffering from von Willebrand factor deficiency? Number one, dissectional snare method. Number two is the curettage. Number three is the microdebrider. Number four is the coblation. Dissection snare, curettage, microdebrider, or coblation? What is the answer? Dissection snare, the child suffering from von Willebrand factor deficiency. What method of tonsillectomy would you recommend for this purpose? Dissection snare, and you go for curettage, or microdebridor, or you go for coblation. Now, look at me. Look at me, Vital. What is the answer? Very good. In the chat, I can see the online batch chat. I can see that the answer is what? Coblation. Coblation. Very good. Very good, Sunny. Very good, Jafia. Everybody, very great, Sunny. Soumya, everybody. That's nice. Why? Our notes don't have this particular information, but our skull has brain, Vita. Let me tell you, notes, knowledge, notes, information plus common sense is equal to passing the paper. Don't get worried. My notes don't have, your notes have got one relevant deficiency in pathology notes. Your notes have this word of coblation, dissections there in your ENT notes. But what is the common between these two things, beta? You, Soumya, you Reddy, you everyone, you having brain. This plus this and thinking with the brain, and we pass the paper. And we pass the paper. But if you start saying that this is not my notes, something came out of my notes, I have really like submission to make over there. Even if you study for 5 more years, believe me, things will be having like surprises over there. Accept it. Accept it. Don't worry. Don't panic over there. Okay, fine. All of you open up your notes. Okay, fine. Yes. All of you please open up your notes. See whitish membrane on tonsil. Whitish membrane on tonsil. Let us see whitish membrane tonsil. Whitish membrane tonsil is due to most commonly due to what? The answer is Streptococcus pyogenes. Streptococcus pyogenes is the commonest organism. Streptococcus pyogenes is the commonest organism to cause the acute membrane tonsillitis. It is what for GABHS. What is GABHS? Group A beta hemolytic streptococci. Group A beta hemolytic streptococci is the causative organism. Everybody go open up your. I think it's page number is 40. I guess, huh? Fine. Group A beta hemolytic streptococci. Okay, fine. So perfect. Okay, fine. Group A beta hemolytic streptococci. Okay, am I clear? Fine. Now. So cause of whitish membrane tonsillis, don't forget the word GABHS. What is GABHS? Group A beta hemolytic streptococci. Group A. Or they might say group A streptococci. It's okay. Infection mononucleus is caused by EB virus. Diphtheria, don't forget diphtheria membrane is a pseudomembrane. It extends beyond the tonsil. It bleeds on removal. Diphtheria membrane extends beyond tonsil. It bleeds on removal. Diphtheria membrane extend beyond tonsil. It bleeds on removal. Okay, fine. Am I clear? Fine. And Vincent angina is caused by Borrelia vincenti. Borrelia vincenti and fusiform bacillus. Borrelia vincenti plus fusiform bacillus. Borrelia vincenti plus fusiform bacillus. Okay. Borrelia vincenti plus fusiform bacillus. Don't forget diphtheria membrane. Okay, visual question plus bull neck baby. Bull neck. What is bull neck? Bull neck is bilateral cervical lymphadenopathy, and this is a child with fever. Sick child with fever, and bull neck over there. What is bull neck? Bull neck is the large lymph node in the submandibular region. Like that. This is the bull neck picture over there. Am I clear? Yes, please see Walder ring. Everybody, Walder ring is a ring of lymph tissue in the pharynx. Walder ring is a ring of lymph tissue in the pharyngeal area. Outer neck nodes are not part of it. Outer neck nodes are not part of it. Just remember this word Walder ring. Walder ring is ring of lymph tissue. Okay, Walder ring is ring of lymph tissue. Walder ring is ring of lymph tissue outer. Okay, fine. It's the internal mucosal ring of lymph tissue. Outer neck nodes are not part of it. Outer neck nodes are not part of it. Okay. Now everybody go to quinsy. The main thing about quinsy to be kept in mind is quinsy is unilateral. Quinsy is more common in adult. What is quinsy? Peritonsillar abscess. It is a collection of pus between tonsil and its bed. This is the pus. Just see your notes over there. Mostly adult, mostly lateral. Number one, tonsil pushed medially. Number two, uvula pushed to other side. Tonsil push medially, uvula push to the. When I see angulated uvula, the first diagnosis which come to my mind is quinsy. Angulated uvula, think about quinsy. Okay, fine. Now, so tonsil push medially, uvula push to other side, but most important thing is outer neck normal. Look at the note. The outer neck should be normal. Outer neck should be normal. Fine. Now, everybody, please see. Chief complaints are what? Plummy voice, hot potato voice. The classical reason of hot potato voice is what? The quinsy. Quinsy. Hot potato voice seen in many conditions. But if you have to choose one answer, quinsy. Okay. Trismus, difficulty in opening mouth due to spasm of medial pterygoid muscle. Medial pterygoid muscle. Medial pterygoid muscle to find quinsy. So, how to solve this question? Quinsy is having throat pain. Imagine the patient you're seeing in the OPD. Throat pain is there, dysphagia. This is common sense, but two main things are trismus, difficulty in mouth opening due to spasm of medial pterygoid muscle, and hot potato, plummy voice or muffled voice. Hot potato voice, plummy voice or muffled voice. Okay, and the uvula is angulated. Then you think of quinsy. But if along with that plus lateral neck swelling, if quinsy like question come along with that lateral neck swelling, then answer is parapharyngeal abscess. Parapharyngeal abscess, why does it happen? Due to dental infection. This is the teeth, molar, premolar, and one or tooth got caries, and that spread this swelling. This is the lateral neck swelling. The only thing is to remember lateral neck swelling. Parapharyngeal, na? Lateral neck swelling will be there. Lateral neck swelling will be there. Okay, parapharyngeal abscess. Please written over there. If same history and examination finding as of quinsy are given in the question, along with that, there is a lateral neck swelling close to angle of mandible, then answer will be parapharyngeal abscess. Okay, fine. What is Quincke disease? Quincke disease is not quinsy. Quincke disease is angioneurotic edema of the uvula. Angioneurotic edema of the uvula. Quincke is not quinsy. Quincke, do not confuse with the word quinsy. I hope you remember the class I told you. Don't reach Jal Mahal. Reach Jai Mahal. Jai Mahal. Okay. So don't reach and don't make mistake. Jaljai. Quinsy. Qui. Quincke is idiopathic edema of uvula. Do not confuse this word with quinsy. Everybody, orange colored tonsils. Anybody? Orange colored tonsils are seen in which disorder? Orange is tang. Tang is what? Tangier disease. Tangier's disease. Yes. Tangier disease. Tangier disease, tang. Orange colored tonsil are feature of Tangier disease. Now, OSMF, oral submucous fibrosis, is what? White palate. It is due to tobacco chewing. It's a pre-malignant condition. White palate. Okay, white palate. Oral submucous fibrosis. Can you see why patient note tobacco chewing, betel nut chewing, supari, and all that? White palate, and this patient will be having which symptom? Trismus. The last page of pharynx is this one. Trismus will be there. So tobacco chewer with trismus and fibrosis in the mouth. This oral submucous fibrosis. It's a pre-cancerous condition. Ludwig angina is simple. Ludwig angina is infection of the mouth. Basically, there are molar, premolar. One of the molar premolar got infection, and that led to the midline chin swelling. This is the midline chin swelling. Midline chin swelling is Ludwig angina, but if dental infection causes the lateral neck swelling, is parapharyngeal abscess. Lateral neck swelling is parapharyngeal abscess. Both stories are due to dental infection. Don't be in a hurry after reading dental infection. Two type of neck swelling can come in dental infection. Lateral neck swelling is the parapharyngeal abscess, and midline chin swelling will be Ludwig angina. Basically, infection of floor of mouth, also called submandibular space, and source of infection is dental caries. After dental caries, we have got what? Chin swelling. The chin. Please see midline chin swelling. Okay, lateral neck swelling will be parapharyngeal abscess. Trismus is there in this also. There may be breathing difficulty. What is the causative organism? Streptococci and anaerobes. streptococci and enros. Treatment is external IND and a breathing difficulty there, then tracheostomy to be done. Tracheostomy. Guys, don't forget the word leukoplakia. Leukoplakia, you know from surgery also, white patch. And both of them, OSM and both are what? They are pre-malignant condition. Look at the last page of your pharynx. Commando operation. Most common site of oral cavity cancer in India is buccal mucosa, gingivo-buccal sulcus. Look at the last page of pharynx. Most common site of oral cavity cancer in India is buccal mucosa. But which part of buccal mucosa? Gingivo-buccal sulcus. And when mandible get involved, the name of surgery is commandos operation. What is the last letter? But a commando operation is done for oral cavity cancer. Commando operation is combined oromandibular resection with reconstruction. Combined oromandibular resection with reconstruction. Guys, anything which coming to your mind about pharynx topic, which we have not done? We're done. The four champion topics are adenoid, angiofibroma, nasopharyngeal carcinoma, and tonsillectomy related question. Right? Tonsillectomy related question. Then abscesses are there, but quinsy, parapharyngeal abscess, Ludwig angina, etc. All okay, everybody? All okay? Anything in your mind coming which you want me to revise with you before we take the break and finally come back for larynx actually. When we come back next now, open up your larynx first page, then we start from there. Everybody, tell me, are you okay? Everybody, all okay? Tell me in the chat box. Okay, fine. Gingivobuccal sulcus, yes. Danger disease, yes. Correct. Let's take the last break now. 15-minute break. 15-minute break, and the last session will be till 3 p.m. And in this time, let's revise the larynx. Then you also revise the larynx, everything one more time, and then you appear in that 100 question systematically. Don't be in a hurry. Then that's all. No, fine. Okay, fine. Can we take a break now? We take a break now. Okay. No, if no question, yes. Okay, fine. 15-minute break, huh? 15-minute break. We started 1:20, I guess. Yes. 1:20 we start. Hello, everyone. Please confirm, are you there? We can start the larynx revision now. Okay, fine. One second. So, guys, let's start larynx revision. Sorry for the delay. I was just setting the file. So, larynx, first of all, the level of larynx is from C3 to C6 in adults. The upper border of the larynx is at C3, lower border of larynx is at C6. Look at a picture on the first page of your notes. So C3 is the upper border of the larynx and C6 lower border, And thyroid upper border is at C3, cricoid lower border is at C6, and hyoid bone is not a part of larynx. Very famous question. Hyoid bone, is it a part of larynx? No. Hyoid bone is not part of larynx. It is above the larynx. But epiglottis is projecting above the level of the hyoid bone. So because epiglottis is a long leaf, it projects above the level of the hyoid bone. My different thyroid and cricoid make the outer framework of larynx. Thyroid and cricoid make the outer framework of larynx. Upper border of thyroid is at C3, lower border of cricoid is at C6. And what is the role of the arytenoid? Now, arytenoid make posterior one third of the vocal cord. This A is arytenoid. Arytenoid make posterior one third of the vocal cord. So these are what? Arytenoids over there. So arytenoids make posterior one third of the vocal cord. Arytenoid make posterior one third of vocal cord. And of course, this picture shows very clearly that the upper border from the lower border is important question. In children, it is different. In adult, different. So in adult, it is C3 to C6. In children, it is C2 to C3. So for adult larynx level is C3 to C6. So fine. Now guys, my dear friend, cricothyroid membrane is important because it has been asked in examination also. There are two membranes in the larynx. One is thyroid membrane between thyroid and hyoid, and number two is cricothyroid membrane. Now, cricothyroid membrane is a site of surgery called cricothyroidotomy. Cricothyroid membrane is a site of surgery called cricothyroidotomy. Which surgery is shown over here? The name is cricothyroidotomy. Now, you can see over there in your notes also, somebody has cut it open over here and somebody has put a tube through that, the file. Now, to give airway. Now, it's a site of surgery called cricothyroidotomy. It's a rarely done surgery, not commonly done surgery, rarely done surgery for airway. It's an airway surgery, but a rare surgery. The more common surgery will be tracheostomy. More common surgery is tracheostomy. Okay, but the thing is, it's a quick surgery and it's a bedside surgery. This is a very quick. Tracheostomy might take time, but this is a very quick surgery. So it is only done when tracheostomy time is not left. You are not having instrument or the technique or the time for left for tracheostomy and patient is dying over there. It gives airway support for less than 48 hours. 48 hours. If you need more airway support, you will have to do tracheostomy. It gives airway support for less than 48 hours. If more airway support needed, if more airway support is needed, then it should be followed by tracheostomy. It should be followed by tracheostomy. So it is an alternative procedure to tracheostomy, but it's a rare procedure because it is actually going to damage the larynx. So, and it gives airway support for only less than or equal to 48 hours. If you need more airway support, then you need to do tracheostomy. The problem is cricothyroidotomy permanently can damage the larynx. It can damage larynx. Why it's not a very preferred surgery? It's a quick surgery. It's a bedside surgery for airway, very quick one. But the only problem is it damages larynx. You're opening the larynx, it damages. That's why it's not. That's why therefore rare. Therefore rare surgery. Okay, now, next topic is the, correct laryngeal mucosa. Larynx lined by ciliated columnar epithelium, pink in color, but the white vocal cord are lined by stratified squamous epithelium. Please see over there. So larynx lined by ciliated columnar, put an arrow pink in color, except vocal cord which are lined by stratified squamous epithelium. That is why we have got the white vocal cord. White vocal cord are there. VC mane vocal cord. Okay, fine. Now, keratosis larynx is what? Sometimes this stratified layer starts shedding faster in smokers, and look at the disease is called keratosis larynx. What is the name of the disease? It's called keratosis larynx. What is that? Look at the notes. In some smokers, vocal cord epithelium starts shedding faster, and it lead to deposition of white keratin on the vocal cord. It's called keratosis larynx. Keratosis larynx. Now, problem is it is seen in smokers. Yes, it's a pre-malignant condition. It can lead to cancer. It can lead to cancer. Now, the same topic continue. Please see over there. The chief complaint of this will be what? The horse voice. The technical name of horse voice is dysphonia, and the history of smoking will be there. So this is endoscopic picture. The endoscopy will be showing what? The white keratin patch on the vocal cord. Treatment is what? Surgery. What is the treatment? Surgery. What is the name of surgery? Surgical treatment. What is the name of surgery? Stripping of vocal cord mucosa. Look at the picture or your notes also. Vocal cord should be mucosa should be removed. Also called decortication plus quit smoking. Of course, smoking and other treatment is carbon dioxide laser cordectomy. Other treatment is CO2 laser cordectomy. Carbon dioxide laser cordectomy. CO2 laser cordectomy. So this was the topic of what? Keratosis larynx. So I repeat, the keratosis larynx means the vocal cord epithelium starts shedding faster. It is seen in smoker. Patient is a smoker with a history of hoarse nerve voice, and the hoarse nerve voice called dysphonia. Treatment is surgery. Remove the mucosa. It's called stripping of vocal mucosa, called decortication. Plus quit smoking. Which laser can be used? With a carbon dioxide laser can be used, and CO2 laser is the most popular laser for any laryngeal procedure. CO2 laser is the more popular. CO2 laser cordectomy. Okay, CO2 laser cordectomy. Now, pitch disorder of voice, my dear friend. Normal voice feature in adults. Children have got almost same voice, but normal voice feature in adults. Please see over there. The males have got low pitch voice or dull voice, and females have got high pitch voice or sharp voice. Males have got, this is the normal voice. What is pitch? Pitch means frequency. What is pitch? Pitch means frequency. Pitch means frequency, okay? Clarity. Males have got low pitch voice. Look at my voice, dull voice, and female voice will be more high pitch voice, sharp voice. Sharp voice, clear voice. Now, the puberphonia. Puberphonia is the first disorder. Disorder. Something not in the order is disorder. So this is not the first thing was the normal finding. Now this is disorder starting over there. Disorder. Look at the notes for a pitch disorder. Now puberphonia means high pitch voice in males. Male should have low pitch voice. High pitch voice in males is the puberphonia. It's very emotionally labile, shy male. This is going to be emotionally labile, shy young male. Shy young male. Okay, fine. Well, so patient needs A, speech therapy, and B, psychotherapy. What is the name of speech therapy maneuver? Gutsman maneuver. Look at, remember, hold thyroid cartilage, press it backward and speak. Look at me, everybody. Oh, man, have guts, speak like a man. Look at the name. Gutsman maneuver. Gutsman. Gutsman. Oh, man, have guts, speak like a man. This maneuver is used for treatment of which condition? Puberphonia. Why psychotherapy? Because the patient is very shy. Psychotherapy is also needed. Now, if speech therapy also fails, then we do a surgery called type 3 thoroplasty. Now, type 3 thoroplasty is the preferred surgery if the speech therapy fails. Now, type 3 thoroplasty is what? It is surgical shortening or loosening of vocal cord. The correct scientific word is loosening. Okay, shortening, yes, shortening or loosening of vocal cord. Okay, fine. Puberphonia is what? When a man speak like a woman, and like I told you, Narendra Modi speak like Mamata Banerjee. Okay, fine. Shortening or losing a vocal cord, and that. Androphonia mean when Mamata Banerjee speak like Narendra Modi. Okay, fine. This is what? This is the low pitch voice in female. This is low pitch voice in female. Low pitch voice in female. Low pitch voice in a female. Female should have a high pitch voice. Low pitch voice in a female is the androphonic voice. And for this, the surgery will be required. What? Type 4 thoroplasty. Type 4 thoroplasty is what? Type 4 is surgical lengthening or tightening of vocal cord. My different surgical lengthening or tightening of the vocal cord. Fine. So this is type 3 thoroplasty is shortening, loosening, and type 4, look at the notes over there. Type 4 is lengthening or tightening of vocal cord. But lengthening or tightening of vocal cord. Now, all okay, everybody fine? Okay, now. Now, everybody, now there are four thoroplasty. Let's revise them. Let's revise them. Type 1, if you remember, type 1 is MAD, medialization done for adductor palsy of vocal cord. Type 2 was go to lab, lateralization done for abductor palsy. Type 3 is shortening, loosening for puberphonia. And type 4 is lengthening, tightening for androphonia. Type 3 and type 4 are opposite of each other. Type 1, type 2 are opposite of each other. Let's revise. Type 1 is MAD, mean medialization done for adductor palsy. Type 2, lateralization done for abductor palsy. Type 3 is shortening, loosening done for puberphonia. Type 4, lengthening, tightening done for androphonia. This is the pitch disorder of the voice. Okay, now next question, brother. Laryngocele. Laryngocele is what? Abnormally dilated saccule. What is saccule? Saccule is mucosal outpouching from ventricle. What is saccule? Saccule is outpouching from saccule is normal structure. Everyone has got saccule. Saccule is a part of supraglottic area. If you remember this picture, this is your saccule. Saccule was a small outpouching from ventricle. If you remember, there are false vocal cord, there are true vocal cord. Fine. This is your saccule over there. Everybody has got saccule? Yes. Okay. And if saccule become big, it's abnormally dilated saccule. Okay. I'm not. So it is typically seen in people who are, wind instrument blower. Wind instrument, look at your notes. Wind instrument blower like trumpets, saxophone, bagpipers, or glass blower or glass blowers. Okay, fine. So basically, it is chief complaint is what? The chief complaint is air-filled neck swelling. There is a neck swelling question in a patient who is a trumpet blower. Air-filled neck swelling. Air-filled neck swelling, and that gives Bryce's sign. So Bryce's sign is what? Sound of air leak heard when laryngocele is pressed. Sound of laryngocele heard when laryngocele is pressed. And how do you do X-ray? X-ray is done with Valsalva. This guy is doing what? Is doing Valsalva. X-ray done with Valsalva. So this is the X-ray we do. X-ray with Valsalva will make the swelling more prominent, easy to see. And lastly, Valsalva is the keyword. Laryngocele pierces which membrane to come out? Thyroid membrane to come out. Laryngocele pierces which membrane to come out? Thyroid membrane. Laryngocele pierces thyroid membrane to come out. Am I clear? Fine. So this was about the laryngocele. So everybody, let's revise. Saccule is a normal structure. It is small mucosal outpouching ventricle. If saccule become big in size, it's a disease called laryngocele. The typical story will be glass blower or trumpet blower with the air-filled neck swelling, and the name of sign is Bryce's sign. For X-ray, the classical word is what? For X-ray, the word is Valsalva. X-ray, the word is Valsalva. Okay, because there's a clue in the paper like that. X-ray, the word is Valsalva. X-ray with Valsalva. Now, Rinke edema. Rinke edema. Now, all of you, this is next topic now. Rinke edema. 1 second. Please do make sure that give 1 hour to this whole PDF and see it in the 2 hour. You see this whole thing is like it's going to really make main point. Rinke edema. First of all, what is Rinke space? Rinke space is this space. This yellow space is Rinke space. What is Rinke space? It is the submucosal loose connective tissue of the vocal cord. This is the yellow thing is the Rinke space, and edema of the space called Rinke edema. It bilateral diffuse swelling of vocal cord. This is a visual question of the paper also. You can see both sides symmetrical swelling of the vocal cord. And the most common cause is smoking. Look at the note. Smoking is the most common cause. Smoking is the most common cause. And chief complaint, yes, very famous question. Chief complaint is dysphonia. What is dysphonia, anybody? What is dysphonia? Hoarse voice. What is dysphonia? Hoarse voice. Again, Rinke edema, the history will be smoking, but photo will be given over there of the bilateral symmetrical diffuse swelling of vocal cord. Again, the treatment will be surgery in the form of stripping of vocal cord mucosa. You have to remove the mucosa and the fluid will come out and the new mucosa will come automatically. Am I clear? This much is clear. Now, vocal nodule is again a very important topic. PYQ also star topic. Vocal nodule. Vocal nodule also called the teacher's nodule. Teachers or singers nodule. Same page, the same page. Teachers or singers nodules. And the main reason is vocal abuse. Vocal abuse. Plus minus second cause is LPR, laryngopharyngeal reflux of gastric acid. LPR. So cause number one, vocal abuse. Number two, LPR, laryngopharyngeal reflux of gastric acid. Now look at this visual question also. Photo is also important. Nodules are always bilateral. Nodules are always bilateral. Okay, fine. And they are always bilateral and they are seen at the junction of anterior one third and posterior two third. The anterior one third, posterior two third. They're seen at the junction of anterior one third and posterior two third. And the MCQ is what? Treatment. Don't write surgery. Please understand. Don't write surgery is not the primary treatment. The primary treatment is speech therapy or voice rest plus proton pump inhibitor. Why proton pump inhibitor? For LPR. What is LPR? Laryngopharyngeal reflux of gastric acid. Let's revise. First of all, rhynchic edema. Rhynchic space is the subepithelial loose connective tissue layer in the vocal cord. Edema, the space called rhynchic edema. It's bilateral diffuse swelling of vocal cord. And the most common cause is smoking. And chief complaint is dysphonia, hoarse voice, and surgery is required in the form of stripping of vocal cord mucosa. Now, vocal nodule called singer nodule, screamer nodule, teacher's nodules. They are due to the vocal abuse, number one. Number two, they can be due to the laryngopharyngeal reflux of gastric acid. Nodules are always bilateral and they're seen at the junction of anterior one third and posterior two third. And the treatment for this would be speech therapy or voice stress plus minus proton pump inhibitors also. Next topic in your notes revise vocal polyp. Vocal polyp is cause is same, symptom is same, but site is same. Only difference is polyp is actually unilateral. Polyp is unilateral, and for polyp we do a surgery called MLS. What is MLS? Microlaryngeal surgery. For polyp is do surgery, microlaryngeal surgery. It is surgery of vocal cord under microscope. And what is the focal length of ENT microscope? Please see ENT234. For ear surgery, we do which focal length? 200 or 250 millimeter. For nose, 300 millimeter. And larynx for MLS, 400 millimeter. So once again, the focal length of ENT microscope, ENT, E200, 250, nose 300, larynx, MLS, 400 millimeter. Okay, fine. Next one is intubation granuloma. Cause is iatrogenic, faulty or prolonged intubation. Faulty or prolonged intubation. Iatrogenic. Iatrogenic is faulty or prolonged intubation. Okay, fine. Now, for example, after surgery under general anesthesia, please see, or in the ICU patient. Please see, everybody. Now, two questions coming your way. GA oblique ICU story. And two questions can be crafted out it. Please make it out. Please do remember it. One is this topic which you are reading right now, hoarse voice. Voice problem or vocal cord problem? This is intubation granuloma of vocal cord. Vocal cord problem, voice problem. Intubation granuloma of vocal cord. But if they say patient develop respiratory distress after few weeks, after few weeks of discharge from ICU. This question is likely. Respiratory distress plus minus stridor. Patient was successfully discharged. Anybody who can tell me? Patient was successfully discharged from ICU. After a few weeks, the patient developed breathing difficulty. Then what went wrong in that? Answer is subglottic stenosis. Means the prolonged intubation has caused damage to the cricoid ring, and the space in the cricoid ring is the subglottic area, and the prolonged intubation caused damage to the internal lining of the subglottic area, and that led to fibrosis in that area. That's why breathing discomfort started after a couple of weeks from discharge from ICU, and this is the diagnosis of subglottic stenosis. Are you able to correlate to these questions? Everybody, are you able to correlate to these questions? GA or ICU story after a few weeks. After a few weeks, not immediately, after a few weeks. After few weeks, two questions are possible. Don't jump at intubation granuloma only. This question is likely. I'm telling you. After a few weeks of ICU stay, patient went home, was absolutely all right. Now he developed breathing difficulty and stridor. What is the diagnosis? Most likely, this is a subglottic stenosis. Why it happened? Because of prolonged intubation. Now, come back to intubation granuloma. Intubation granuloma is bilateral. Again, bilateral. It's at the junction of anterior two-third and posterior one-third. My different nodule was junction of anterior two-third, anterior one-third and posterior two-third. Granuloma is at the junction of anterior two-third and posterior one-third. And treatment is the prolonged in the MLS surgery, MLS microlaryngeal surgery. Microlaryngeal surgery. In your notes, you can quickly revise. After that, in your note about JPL. Everybody revise JPL, juvenile papilloma of larynx. JPL, revise. Juvenile papillolarynx is what? Please keep in mind, it is due to the HPV 6 and 11. Age is juvenile 3 to 4 years. And patient source of infection is mother having genital HPV. The clinical story will be viral HPV warts in the larynx. It's a pre-malignant disease. Patient will be 3 to 6 year with chronic hoarseness of voice with or without breathing difficulty. And then the patient would be needing surgery. Which laser is used to remove this papilloma? Carbon dioxide laser. CO2 laser is used over there. Okay, fine. Now, next topic is in your note, please see difference between pediatric and adult larynx. All of you, please see difference between pediatric and adult larynx. So, pediatric larynx is what? C2 to C3. Adult is C3 to C6. High larynx in infant prevents what? Aspiration of milk during breastfeeding. Okay, high larynx C2, C3. Why? Especially prevent aspiration of milk during breastfeeding. Narrowest part of children is subglottis, adult is glottis. Very famous question. Narrowest part of children is subglottis, adult is glottis. Very famous question. And there is more soft tissue in children, larynx, as compared to adult. Therefore, children get more edema of larynx after infection. Therefore, children get airway problem after infection. Okay, now. Guys, please, this table is very important. Narrowest part of pediatric larynx is subglottis. Adult, it is glottis, brother. And then the high larynx in children prevents aspiration of milk during breastfeeding. This is something to be kept in mind over there. Okay, fine. This is important. Okay, let's fill in the blank. So C2 in the narrowest part in pediatric larynx is subglottis, adult is glottis, and high larynx infant prevents aspiration of milk during breastfeeding. We have done that. Now, next is what in your notes with the indirect laryngoscopy, OPD procedure with the mirror. Which structures are not visible on IL? IL does not show anterior commissure of vocal cord because it is covered by epiglottis. IL does not show what? IL does not show what? IL does not show anterior commissure of vocal cord covered by epiglottis. Number two, undersurface epiglottis. Number three, undersurface vocal cord, ventricle saccular hidden area. What is ventricle? Space between false cord and true cord. And what is saccule? Mucosal outpouching from ventricle. Now, next one is what? Stridor is very important. Stridor means noisy breathing and its cause is airway obstruction. Whenever air passes through a narrow passage, it generates sound. Okay, fine. Stridor is noisy breathing and there are three types of stridor depending on the level of blockage. Very famous question is what? Inspiratory stridor due to blockage of what and what? The answer is pharynx and supraglottis. Pharynx and supraglottic problem lead to inspiratory stridor. Pharynx and supraglottic problem lead to inspiratory stridor. Yes. And biphasic stridor due to glottis, subglottis, cervical trachea, expiratory stridor, thoracic trachea plus bronchi. So higher problem, inspiratory stridor, lower problem, expiratory stridor, middle problem, biphasic stridor. Guys, please do keep in mind, supraglottic problem lead to inspiratory stridor and subglottic problem lead to biphasic stridor. Let us write two example of supraglottic problem. Number one is laryngomalacia. Laryngomalacia causes supraglottic stridor. Okay, number two, the laryngomalacia causes inspiratory stridor due to supraglottic problem. And number two, acute epiglottitis. Acute epiglottitis. Acute epiglottitis is again supraglottic infection, therefore it causes inspiratory stridor. The classical example of subglottic involvement causing biphasic stridor is ALTB or croup. ALTB or croup. Okay, fine. Now, everybody, lymphatic drainage of larynx. Lymphatic drainage of larynx. Vocal cord do not have lymphatics, remember? So prognosis will be very good for pure glottic cancer because of no neck node metastasis. Prognosis will be good for the pure glottic cancer. Fine? Am I clear? So, because vocal cord cancer do not spread, therefore they have got a good prognosis. Now, all of you open up the two pediatric infection. Let us do acute epiglottitis. Everybody open up the notes. Tell me what page number. Which page number? Acute epiglottitis is a pediatric laryngeal infection. Okay, fine. Now, somebody asked about the intervening granuloma. Yes, the Shantanu, somebody asked this story again. After ICU stay, particularly, after ICU stay, after a couple of weeks of ICU stay, properly discharged from ICU, all went well, patient went home. After few weeks of that story, if patient develop hoarseness of voice, then vocal cord problem. What is vocal cord problem? Intubation granuloma vocal cord. But if after few weeks of ICU discharge, patient develop again breathing difficulty and stridor, it's a case of subglottic stenosis. Now, all of you, page number 19. Acute, everybody open up. Let's revise acute epiglottitis. Let's revise together. Acute epiglottitis. Page number 19, yes. It is the bacterial infection of supraglottis. Most common bacteria is Staph pneumoniae. Second common is Haemophilus influenza B. Okay, fine. Age is 2 to 7 year, not infant. It's a very child in pediatric emergency. It's a triage category red. You know triage category? Triage category red over there. Okay, fine. Now, the respiratory difficulty is severe. Stridor. You tell me what type of stridor? Inspiratory stridor. Why? It's a supraglottic infection. Then high fever, drooling of saliva, hot potato voice, and child sits bending forward. What is the name of sign? What is the name of sign? The name of sign is tripod sign. Name of sign is tripod sign. If you do X-ray of this baby, you will see which sign? Thumb sign. Thumb sign is what? Swollen epiglottis is called thumb sign. What is the first treatment of this patient? The answer is airway management by intubation. Then steroid and antibiotic to be given. What to prevent, what to avoid before intubation is repeated laryngoscopy, feeding tube insertion, rectal temperature probe insertion, or blood sampling, because all these things can lead to sudden laryngospasm, which can be very dangerous for the patient. Okay, fine. Now, okay, fine. Fine. Yes, repeated laryngoscopy, rectal temperature, then feeding tube insertion, blood sampling should be avoided before laryngoscopy. Let's revise the main point. Don't forget the tripod sign, thumb sign, and don't forget the child condition. Child is very sick, SpO2 is very down, respiratory distress is severe, inspiratory stridor is there. First treatment is airway management by intubation. Second topic is ELTB. Everybody, next page, next page, next page. Let's do page number 20. ELTB, acute laryngotracheobronchitis or croup. Very, very important topic. Look at the name. Let's revise. That is bacterial. First of bacterial, this is viral. It's viral infection of complete airway, but subglottis is most affected part. What is the most affected part? Subglottis is most affected part. It is caused by para-influenza virus. It's caused by para-influenza virus. Okay. Now, age is 3 months to 3 years. Boys more than girls. Now, in this case, there is respiratory difficulty, but mild. Stridor is biphasic, low-grade fever, barking cough due to bronchospasm. Everybody tell me what is the X-ray of this? What is the X-ray sign of? Tell me what is the name of X-ray sign? Steeple sign. What is the name of X-ray sign? Steeple sign. Steeple sign is what? Steeple is the narrowing of subglottic area. My dear friend, this is the steeple. Okay, steeple. Okay. Anybody want to tell me if I put arrow over here on the side of the larynx, which area I am indicating? If I put arrow over here, which area I am indicating? Anybody? Not that white arrow is steeple sign, but if I put arrow on the side of the larynx on the X-ray, which area shall I be marking? You tell me, you ask me, Rajiv, give us four choices. Four choices, your democratic right. Four choices is your democratic right, beta. I'm telling you. Number one, esophagus. Number two is vallicula. Number three is the pariform sinus. Number four is the supraglottic area. Number one, esophagus. Number two, vallicula. Number three, pariform sinus. Number four, supraglottic area. What would you like to mark through yellow arrow? White arrow is steeple sign. What about the yellow arrow? The yellow arrow will be what? What answer is pariform sinus. Any arrow on the side of larynx is which area? Pariform sinus region. Any arrow on the side of the arrow will on the side of the larynx will be the side. This will be pariform sinus region. Pariform sinus. Remember we said that larynx, like on the side of that, if put to arrow, is pariform sinus region. Of course, this is also pariform sinus region. Okay, fine. It's pariform sinus region. Fine. Okay, fine. So this was about the acute epiglottitis and laryngotracheobronchitis. This is important topic for you. One second. There's any question till this level, beta? Any question anyone has? Anyone? Any question till this level? Okay, fine. Now, ALTB, you done that? Fine. ALTB. Okay. Now, I'm going to mark in this X-ray. This, of course, is the steeple sign, but if they put arrow on the side of this, the yellow arrow is piriform sinus. What I was asking now, piriform sinus. Okay, this one. Of course, this is the steeple sign. Narrowing of subglottic area is the steeple sign. But in the NEET PG, one time they try this X-ray and they put the arrow on the side of this thing, and the side of will be piriform sinus region. Then where is vallicula? The vallicula is at the oropharynx level. Vallicula will be here. Vallicula will be here. Vallicula will be here. This can come in radiology also, my dear friend. This can come in radiology in exam. So just keep in mind that the any arrow on the upper part, any arrow on the in the uppermost part will be what? Any arrow will be there. What will be that? Can you tell me what is the name of this sign? Imagine only this came. Young boy with nasal bleed. What is the name of this one? A young boy, nasal bleeding. What sign you are seeing over there? Is what? Is Holman Miller sign. Of course, Holman Miller sign. Only thing is, the CT given is the sagittal CT now. Sagittal. We saw the axial. Yes, very good. Now, everybody come to laryngomalacia. Sorry. So, in ALTB, steep% treatment is humidified oxygen. Humidified oxygen treatment is humidified oxygen, bronchodilator. Bronchodilator, which bronchodilator? Epinephrine or adrenaline nebulization. Epinephrine or adrenaline nebulization. Steroid dexamethasone. But antibiotic has no role. Antibiotic has no role. Why? It is viral infection. We don't give salbutamol. So better is the epinephrine or adrenaline. Okay, fine. Now, Laryngomalacia. Everybody go back to laryngomalacia. Open up your books. Laryngomalacia. Tell me the page number. All of you, let's revise laryngomalacia. Very, very important topic. Laryngomalacia. Laryngomalacia, page number is 17. Yes. Laryngomalacia, let's revise. It's the most common congenital anomaly of larynx. It is also called congenital laryngeal stridor. It is the most common cause of neonatal stridor. It is weakness of supraglottic area. Therefore, on examination, we see omega-shaped epiglottis. The chief problem is stridor. 4 point word stridor are: number one, inspiratory stridor. Number two is stridor start in first week of life. Stridor increases after crying and suckling of milk, and stridor is less in the prone position. Let's revise once again. 4 point word stridor. What is stridor? Noisy breathing since birth. Mother will say, Dr. Daman, it came in the first week of life. Type of stridor is inspiratory or expiratory? Answer is inspiratory. Why? It's a weakness supraglottic area. Number three, stridor increases after crying and suckling of milk, and stridor is less in the prone position. But the cry, next page. But the cry sound of the baby is normal because vocal cord are normal. Don't forget this picture of omega shaped epiglottis. Treatment, yes. Treatment is the child has no hypoxia, no cyanosis. Tell the mother that baby will get all right in next coming 1 or 2 years. But the treatment is conservative treatment. Reassurance to the parents, it is self-limiting condition. Let's revise once again. Laryngomalacia, very, very possible topic. It is the most common congenital anomaly of larynx. It's also called congenital laryngeal stridor. It is most common cause of neonatal stridor. It is weakness of supraglottis, and examining finding is omega-shaped epiglottis. There are 4 point word stridor. Number one, inspiratory stridor. Stridor start in first week of life. Stridor increases on crying and suckling of milk. And stridor is less in the prone position. And the cries on the baby is normal because vocal cord are normal. Treatment is conservative because the baby has no hypoxia, no cyanosis. Reassurance to the parent is self-limiting condition. Now, therefore, conservative treatment. Treatment is conservative. Okay, fine, everybody. Let's start the next one now. Okay. Now, everybody go to the voice disorder, rhinolalia clausa. Dull voice. Rhinolalia clausa is what? Dull voice. Anybody will tell me what is the most common reason behind it in a child? What is the most common reason behind dull voice or hyponasality of voice in a child? Yes, adenoid hypertrophy. Look at your notes. Most common cause is adenoid hypertrophy that lead to rhinolalia clausa. Number two is sinusitis or upper respiratory infection. Number three, nasal polyp and nasal tumors. Anything which lead to the closed nose. Please see rhinolalia clausa. Rhino means nose, clausa means closed. Nose is closed. Nose is closed. The main question to remember is adenoid hypertrophy causes rhinolalia clausa. Adenoid hypertrophy causes rhinolalia clausa. Now, on the same page, we have got the upper part, functional or hysterical aphonia. Functional hysterical aphonia, patient is pretending the symptom of sudden loss of voice. Patient is pretending the symptom of sudden loss of voice. Actually, voice is normal. Functional or hysterical aphonia, patient is pretending the symptom of sudden loss of voice. Actually, the voice is normal. Fine. Now, it's a psychological problem. It is a psychological problem. Psychological problem, okay? The more common in young females. 20 to 30-year-old, and normal cough sound proves the diagnosis. The one who can cough can speak. A normal cough sound proves the diagnosis. Treatment is psychotherapy or psychiatrist consultation. Very easy question to crack. Anytime you get a young lady with sudden loss of voice, please mark common answer. Always don't become neurosurgeons, rheumatologists on that day. Don't mark rare things. You can see Dr. Dhawan, patient can have vocal cord palsy also. Yes, she can have cord palsy. Yes. But he asks you what is the most likely diagnosis? A 19-year-old girl presenting to emergency with sudden loss of voice, and what the diagnosis. Now, few people will be like Einstein's in the group actually, who say, my notes have got 20 to 30 years. So this lady is 19 year. It cannot be functional aphonia. Okay, then they will mark bilateral adductor paralysis of the vocal cord. And my notes have got 20 to 30 years. My God, please don't be so rigid, beta. Please don't give that much importance to notes, beta. Don't go to exam with the burden of the notes. Good 19-year-old female, it's okay, no problem. What is your problem in that? Maybe it's birthday tomorrow. She's turning tomorrow birthday. Before birthday, she's troubling the parents. Why? Because parents are not allowing to buy iPhone 17. She has been demanding for her 20th birthday iPhone 17, but their parents are not agreeing to that. So, day before her birthday, she has created a story over there and she has created a problem for the family. She stopped speaking over there. But your notes have got 20 to 30. Question in the exam is 19-year-old female. If you change the answer, then I think you are behaving like an 11th class student. You are not that. You will think like a doctor. Okay, that is where we have to really see. Okay, fine. It can be 19 also. Now, let us everybody go to muscle of larynx. Everybody, muscle of larynx. Vocal cord abductor, adductor. There is one abductor. Only abductor is very, very famous question. Only abductor is posterior cricoretinoid. Remember, the vocal automatic gate, please see automatic gate. Closing needs more power, opening is a natural recoil phenomenon. Closing, adduction need more power, abduction is a natural recoil phenomenon. Adductor are four: thyroretinoid, interretinoid, lateral cricoretinoid, and cricothyroid. Let's revise once again. There is only one abductor is posterior cricoretinoid. There are four adductor: thyroretinoid, interretinoid, lateral cricoretinoid, and cricothyroid. Okay, fine. Now, okay, fine. Now, fine. The tensor are two. Cricothyroid is the main tensor of vocal cord, PYQ. Main tensor. They stretch the vocal cord, number two vocalis. Tensor give us quality of voice. You see in your notes. Very important for singers. Very important for singers. Very important for singers. Now, all these muscle lie inside except cricothyroid. One muscle is outside is cricothyroid. This muscle is cricothyroid muscle. Look at this picture in your notes also. Which muscle is outside the human larynx is cricothyroid muscle. Now, if it is outside, therefore, read the next motor supply. Motor supply is what? The all muscle of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of spiral laryngeal nerve, also called external laryngeal nerve, because it is outside. So the name of the nerve will also be what? ELN. What is ELN? External laryngeal nerve. Once again, all muscle of larynx are inside the larynx except cricothyroid. Revise with me. All muscle are supplied by single nerve, RLN, except cricothyroid, which is supplied by external branch of laryngeal nerve, also called external laryngeal nerve. Now, there are two nerves in larynx, RLN, SLN. Both are branches of vagus. Vagus is the mother nerve of larynx. Vagus is the mother nerve of larynx. Okay. So, and RLN, SLN branch of vagus. Now, SLN give two branches, ELN, ILN, and ELN supplies the cricothyroid. And ILN is the main nerve to prevent aspiration. My dear friend, ILN is the main nerve to prevent aspiration. Why? Why? Because It gives sensory supply to supraglottis. Do you know this feeling, na? By chance, some particle enter your this thing, there is cough starting. Why? Vagus is a mother nerve, na? And vagus stimulation will lead to what? Cough. So, which nerve prevents aspiration is internal laryngeal nerve. Don't forget that. Again, vagus, the mother nerve larynx. Two branches are coming from vagus now for larynx, RLN, SLN. RLN is the main motor supply of the all muscle except cricothyroid. So, SLN give two branches, ELN, ILN. ELN supply the cricothyroid and ILN is the main nerve to prevent aspiration. Why? Because it gives sensory supply to supraglottic area. It gives supply to supraglottic area. Now, next one is left side cord palsy. Left side cord palsy is 4 times more common than the right side. Why? Look at the notes. This is because of longer course of left RLN. Now, this is right RLN, this is left RLN. Now, right RLN loops around the subclavian artery. Left RLN loop around the arch of aorta. Okay. What is the name of this gland? The name of this gland is thyroid gland. Thyroid gland. Name of this gland is thyroid gland, and thyroid gland has got very important relation with the nerves. The thyroid gland has got very important relation with the nerves of the larynx. Thyroid gland. Now, this is your thyroid gland, and at the upper pole we have got the SLN or its branch called ELN, and the lower pole we have got the RLN, recurrent laryngeal nerve. At the upper pole, we got the SLN or ELN. At the lower pole, we got the RLN. So when you do the surgery, you have to be really, really careful. Now, for single side cord palsy, treatment is conservative. When one cord is paralyzed, no problem because other cord try to compensate. PYQ. For unilateral cord palsy, single side cord palsy, treatment is conservative because other cord does over movement to meet the paralyzed cord on the disease site. Now, next, thyroid gland relation. The thyroid gland relation, everybody, fine. In this case, no problem. So let's revise once again. Which muscle is outside the human larynx? Answer is the cricothyroid. Therefore, all muscle are supplied by single nerve, RLN, except cricothyroid, that is supplied by external branch of sphenolaryngeal nerve, also called external laryngeal nerve. Also called external laryngeal nerve over there. Am I clear? Fine. Fine. So, and right side cord palsy is less common as per left side. Why? Right is a shorter nerve, left is a longer nerve. Right loops around the subclavian artery, left loops around the arch of aorta. More length of the nerve mean more anatomic relation. More anatomic relation mean more chance of damage in different diseases. Therefore, left cord palsy is 4 times more common than the right side. Okay, fine. Fine. Now, chalo. Now let's go next one. Now bilateral abductor palsy. Practical topic, bilateral abductor palsy. Please see. First of all, vocal cord are in paralysis actually. Abductor mean abduction, palsy mean absent. Look at your notes, everybody. Abductor mean abduction, palsy mean absent. Abduction absent. Abduction absent. Okay, abduction absent. Fine. Now, why it happens? That's a very, very famous question, everybody. Very famous question. Don't forget this question. This has been asked many times, brother. In the this thing also. Okay. In the NEET PG also, brother. Fine. Now, it is the abductor mean abduction. Understand? How to analyze this? Is a practical topic, very likely topic in the paper. Abductor mean abduction, palsy mean absent. Abduction absent, okay? Fine, look at your notes. Look at your main notes. The vocal cord are closed, permanently closed. They are paralyzed, but in which position? They are permanently closed position. They are paralyzed, permanently closed. Now, what is the cause of that? Bilateral RLN injury in thyroid surgery. Please see, imagine this lady. She has got thyroid cancer and there is the RLN nerve on the lower pole to the thyroid gland. While doing surgery, both nerve got damaged. Bilateral RLN injury. Think like a doctor. If this happens, what will be the problem in that case? Please see. The problem will be the only cricothyroid muscle is working. Look at notes, everybody. Look at your main notes. Main notes. Only if bilateral RLN injury is there, only cricothyroid muscle is working, and it is an adductor muscle. And it is an adductor muscle. So both vocal cord will come in the midline position. So both vocal cord will come in the midline position. So both only cricothyroid left, and both cord come in which position? In the midline position. Okay. Now let me put over there in your last PDF to revise. Please see. Now in this case, please see what is happening over there. This one. Now please see this one. So this is happening over there. Fine. Now one second. Yeah. Yeah. So only cricothyroid left, and that bring the vocal cord in the midline position. Respiratory difficulty with stridor. And what will happen in this case will be that patient will be having breathing discomfort and stridor. My dear friend, whenever after thyroid surgery, patient can't breathe properly, it is bilateral RLN injury question. Always remember, whenever after thyroid surgery, patient is not able to breathe properly, it is RLN injury question. RLNG question. So, what is the immediate treatment? Look at the notes. What is the immediate treatment in this patient? Is tracheostomy. Tracheostomy. Then how many months we wait? 6 months. After 6 months, if no treatment is, if no recovery is we seen over there, then the treatment of choice will be what? Treatment choice will be type 2 thoroplasty or lateralization of vocal cord. I hope you remember we said that 2 is lab. What is 2? Type 2 thoroplasty. What is L? Lateralization. AB is abductor palsy. Go to lab. Type 2 thoroplasty is lateralization of vocal cord, also suture chordopexy. You pass suture on vocal cord and pull it outward. It is the type 2. But immediate treatment will be what? Immediate treatment will be tracheostomy. Don't forget, immediate treatment is tracheostomy. Definite treatment is type 2 thoroplasty. Don't confuse the two topics. Immediate treatment is tracheostomy, but definitive treatment is what? Definite treatment is the type 2 thoroplasty or suture lateralization of the vocal cord. Now, let's revise this topic completely, everybody. During thyroid surgery, if bilateral RLN is injured by the surgeon, then after surgery, only one muscle is working, is cricothyroid, because all muscle are supplied by single nerve RLN except cricothyroid. So after surgery is over, the only muscle working cricothyroid and unfortunately adductor muscle. So both vocal cord come in the midline position. So patient get breathing discomfort. Anytime you see after thyroid surgery, patient get breathing problems, stridor, distress after surgery. It is due to bilateral RLN injury, and this is the most serious nerve injury in thyroid surgery. May I say it again? Most serious nerve injury in thyroid surgery is bilateral RLN injury. This question is possible. Most serious nerve injury in thyroid surgery is bilateral RLN injury. Then the immediate treatment is tracheostomy. Then what you do after 6 months, you do type 2 thoroplasty or suture lateralization of the vocal cord. Suture lateralization of the vocal cord. Now, very good, very good. Now, next, if SLN is injured, two branches there. SLN, two branches, ELN, ILN. Let me take you back, everybody. Please see, two branches there. SLN, two branches, ELN. ELN is like cricothyroid. That is the main tensor of vocal cord. If you remember, cricothyroid is the main tensor of vocal. Cricothyroid is the main tensor of the vocal cord. And tensor give you what? Tensor give you quality of voice. Okay, very important for singers. So, and ILN is the main nerve to prevent aspiration. Why? ILN gives the sensory supply to supraglottic area. Now, fine. So what will happen? ELN, ELN, only ELN can also be injured. If they say ELN injured, then what? Okay. Then cricothyroid muscle is paralyzed. It's a main tensor of vocal cord. So patient got poor quality of voice. Okay, right on. Problem in singing. Please look at your notes. Problem in singing. Singing. Examiner shows bowed down vocal cord or lack of tension. And ILN give aspiration issues. Aspiration issue. Now, guys, if the question come, most serious nerve injury in thyroid surgery. Anybody? Most serious nerve injury in thyroid surgery. What is the answer? What is the answer? Bilateral RLN. No, not RLN, not RLN, bilateral RLN. Unilateral RLN will not have major problem. Bilateral RLN. The keyword is bilateral. Yes, RLN, but not unilateral. Bilateral RLN injury. Bilateral RLN injury. Guys, let me summarize. If after thyroid surgery, breathing is a problem, bilateral RLN injury. If after thyroid surgery, singing is a problem, it is SLN or ELN injury. I repeat, if after thyroid surgery, singing is a problem, it is SLN or ELN injury. If breathing is a problem, bilateral RLN injury. Let us do the cancer larynx, everybody. Now we are at the end of the this thing. Anybody, any other topic left apart from cancer larynx, tracheostomy, and foreign bodies? Three topic are not doing now. Very, very important topic. Cancer larynx, tracheostomy, and airway foreign body. Any other topic which we have not done? Laryngomalacia done, epiglottitis done, laryngotracheobronchitis, three important topic. Foreign body will be doing now, tracheostomy will be doing now, cancer larynx will be doing now. Fine. Any other thing which we have? No, all okay. I think muscles done. Okay, fine. And the vocal nodule is important. Ringedema is important. We have done the laryngocele question. Yes. Everybody, can you tell me what is dysphonia plica ventricularis? Dysphonia plica ventricularis. With the page number is 5. If patient produces sound from false vocal cord, disease called dysphonia plica ventricularis. If patient produces sound from false vocal cord, disease called dysphonia plica ventricularis. Dysphonia plica ventricular. Yes, false vocal cord. Freedom keratosolarynx. Cricothyroidotomy is important topic. We've done that. Yes, we've done it. I think let me scan the first page. Take three technique, IL, FOL. This is just for information. Endoscopies are the name there. Then cartilage. Which cartilage are paired, which are unpaired? Thyroid, cricoid, epiglottis are unpaired. And the arytenoid, corniculate, cuneiform are paired. And I think level of larynx done over there. Then cricothyroidotomy, keratosolarynx is important. Laryngocele is large saccule, trumpet blow story, you've done that already. Okay, then we have done the ringedema, don't forget. Okay, fine. Vocal nodule done. Then we can intervening granuloma done. And then I think we have followed up like all, so every this thing actually fine. Yes, correctly. Fine. Now we are coming gradually to the cancer larynx topic. What is the thing to be kept in now cancer larynx, everybody? First of all, cancer larynx. Fine. Cancer larynx is, T1, T2, T3, T4. This can come in the exam. When every T1 means only one named structure involved, like tumor involving epiglottis or vocal cord. T2 means tumor involving more than one named structure, like tumor involving epiglottis and epiglottic fold. Fine. Cancer larynx. Please open up cancer larynx, everybody. Fine. T3 is vocal cord is fixed or immobile. Yes. Cord fixation is, cord fixed or immobile is T3. And T4 is invasion of thyroid cartilage or tumor going into the external structure. Yes, this one is what? This is T4. Cancer larynx. Why? There is invasion of thyroid cartilage over here. T4 cancer larynx is invasion of thyroid cartilage. Okay, now you know glottic cancer. This is T1 glottic cancer. It's of two type, T1A, T1B. Just look at your notes, Sudha. T1A mean one vocal cord involved. T1B is both vocal cord involved. And the important thing is vocal cord should be mobile. Because immobile vocal cord is T3. Immobile vocal cord is T3. Everybody, look at your notes. What is the commonest? Look at the cancer larynx first page. Cancer larynx first page. The smoking alcohol is the causative reason behind it. More common in males 40 to 60 years. Once again, smoking and alcohol both are contributing respectively for laryngeal carcinoma. Male are more commonly affected in 40 to 60 of age. Most common variety of laryngeal carcinoma is glottic carcinoma, generally present with hoarseness of voice. What is the symptom of glottic cancer? Hoarse voice. Chief complaint is what? Hoarse voice. Hoarse voice in a smoker, and you will take a biopsy to make the diagnosis over there. Glottic cancer is of two types, T1A, T1B. What is T1A? T1A means one vocal cord involved, T1B means both vocal cord involved, and vocal cord should be mobile because vocal cord fixed or immobile mean T3, and thyroid cartilage invasion mean T4. This CT scan is T4 cancer larynx over there. Now, treatment of T1, T2 is radiotherapy. T1 is radiotherapy, but nowadays for T1 glottic cancer, laser is better than radiotherapy. Why? Laser is getting more and more in use. For T1 is radiotherapy, but for T1 glottic cancer, laser is better than radiotherapy. For T2, radiotherapy. Okay. So T1, B, T2. T2 is radiotherapy. Now, T3, T4 tumor. Yes, yes, this is something you need to change in your notes. I will highlight in the test and discussion also, because the guideline books have changed now. There's T3, T4. By chance, this question come now because of the recent guidelines. Concurrent chemoradiation has become number one treatment. I agree. In our classes, we have really done the laryngectomy surgery as the number one. No, but the latest edition of our standard PG books has also changed it. It has been now concurrent chemoradiation is number one treatment. If that's not the choice, then number two. Second best is the one you have in your books also. Total laryngectomy using Gluck-Sorensen incision plus minus RND surgery, radical dissection followed by radiotherapy. So T3, T4 tumor, there's an update. I will be doing that in the test and discussion also for a revision. Nowadays, very recently, concurrent chemoradiation has become number one treatment. Number two has become laryngectomy now. Okay, fine. After laryngectomy, we have permanent hole in the neck called permanent tracheostomy. Permanent tracheostomy. Okay. How would you make permanent tracheostomy versus temporary tracheostomy? Permanent tracheostomy has no tube in the neck hole. Now, how would you speak after laryngectomy? So, laryngectomy done, put an arrow. Same topic continue. Three ways are esophageal voice, poor technique, not of much value. Electrolarynx or arteriolarynx is a vibrator, battery operated, touch below mandible. You touch it below mandible and then you vibrate the oral mucosa, and that what you speak. Touch it below mandible to speak. The third is yes. This is star topic of the paper. This is the best option out of the three. TEP device, tracheoesophageal puncture device. Tracheoesophageal puncture device. It's the best option. It is unidirectional valve. It is surgically placed between trachea and esophagus, and the example is Blom-Singer prosthesis. You guys don't forget this picture. It's a PYQ. The blue picture and the green picture both are same. They asked the device Blom-Singer prosthesis. BSP, better write down BSP. This is Blom-Singer prosthesis. I'm written two times. Why? Because both are same picture. Both are showing a different angle of the same thing. Now, this is a star picture. For guys, this picture has three questions. First of all, describe the picture. This is the post laryngectomy patient neck image. I repeat, describe the picture means it's a neck image post total laryngectomy. Number two, what is this big hole in the neck called? Permanent tracheostomy. What is the plastic nipple-like device at the posterior wall of trachea? TEP device. What is TEP full form? Tracheoesophageal puncture device. What is the basic purpose of this? It's a unidirectional valve. It is surgically placed between trachea and esophagus, and patient closes the neck hole with the finger to speak. For intermittently, he has to close the neck hole with the finger to speak. The other provokes and Pange device, but don't forget the BSP, Blom-Singer processes. Blom-Singer processes. Now, everybody open up your notes once again. Let's revise. Everybody open up your notes. Cancer larynx once again. All of you scan the topic with me. Once again, more common in male, smoking alcohol, both contributory factor. The age is 40 to 60 years. Most common variety of pathology is common cell carcinoma, and it has three types. Glottic cancer is the most common type. Chief complaint, hoarseness of voice. T1A means one cord involved. T1B means both cord involved, but cord should be mobile. Okay, now There are no neck node metastases in glottic cancer. Why? Because vocal cord don't have lymphatic, therefore good prognosis. Now, supraglottic cancer, supraglottic above the vocal cord, most common site is epiglottis, and symptoms are mostly of the throat, like throat pain referred to ear, feeling of lump in throat, dysphagia, and then hot potato voice. Hot potato voice. And then come the staging. But the staging, all of we see. T1 mean one named structure involved. Okay. T2 mean more than one named structure involved. T3 mean cord is fixed or immobile. T4 mean invasion of thyroid cartilage or CT scan showing this kind of picture is T4. And the treatment for T1 is radiotherapy. But for T1 glottic cancer nowadays like this, CO2 laser surgery is better than radiotherapy. For T2 radiotherapy, but T3, T4 things have changed now. Concurrent chemoradiation has become number one, followed by total laryngectomy, using Gluxon anesthesia, followed by radiotherapy. After laryngectomy, we have got the permanent tracheostomy, and there are three methods to speak after laryngectomy. Number one, esophageal voice is a poor technique of no value. Number two, electrolarynx or artificial larynx. It's a battery operated handheld external mechanical vibrator. Basically, it touch below mandible to speak. But the best option is TEP device. Lot of question on this have come in EPG also. The basic idea is unidirectional valve surgically placed in trachea and esophagus. The classic example is Blom Singer prosthesis. And this picture is important. This is the neck image after total laryngectomy. This big hole in the neck is called permanent tracheostomy, and this plastic nipple device called TEP device. TEP device. Fine. TEP device. Now is we come to the now next level tracheostomy. Everybody open up tracheostomy. Everybody open up tracheostomy. Everybody can you start tracheostomy now? Okay. Can somebody tell me answer this question? Cancer laryngismal stridulus. Look at your note for laryngismal stridulus is a feature of which deficiency? Laryngismal stridulus is a feature of which vitamin deficiency? Laryngismal stridulus is a feature of vitamin D deficiency or rickets. Laryngismal stridulus is a vitamin D deficiency symptom or rickets. Can you tell me, answer this question? ICU patient on ventilator on a trachea tube for few days, discharged from ICU in good condition, develop respiratory difficulty. What's the diagnosis? ICU patient discharged nicely from the ICU in the good condition. After few days, develop respiratory difficulty. What is the diagnosis? Yes, yes, yes. What is the diagnosis, everybody? Yes, you're right. Answer is subglottic stenosis, not intermittent myeloma. Intermittent myeloma will be hoarseness of voice. Very nice, very nice. Now, all of you open up tracheostomy notes, beta. Indication of tracheostomy. Tracheostomy is a popular topic. It gives question, definitely one question like average. Indian tracheostomy are number one, airway management in respiratory obstruction above the level of trachea. Any problem above level of trachea, if you do tracheostomy, you can bypass the problem. Number two, for prolonged mechanical ventilation, mean ICU patient on ventilator more than 7 days should not be kept on endotracheal tube. If you keep the patient on endotracheal tube for more than 7 days, they can develop this problem, subglottic stenosis. That's why. That's why we do not keep the patient on endotracheal tube for more than 1 week because they can develop prolonged. They can develop the subglottic stenosis. Now, number three, bronchial toilet. What is bronchial toilet? Toilet means cleaning of lungs. Toilet means cleaning of lung. For example, COPD patient in coma. COPD patient in coma. Okay. Now, finally, very important, cuff of the tube. Your exam question. Cuff of the tube help to prevent aspiration. Cuff of the tube help to prevent aspiration. And very, very important indication is the maxillofacial trauma. Maxillofacial trauma, there are two things it do to prevent aspiration of blood and maintain airway. Let's revise once again. What are the various indications of tracheostomy? Number one, for airway management in problem above the level of trachea. Number two, for prolonged mechanical ventilation, mean ICU patient on ventilator more than 7 days. Number three, for pulmonary or bronchial toilet, means COPD patient in coma. And finally, prevent aspiration, mean cuff of the tube prevents the aspiration. And lastly, maxillofacial trauma, in that it will do two advantage, prevent aspiration of blood and maintain airway. Now let's revise. What is the commonest site of tracheostomy? Second and third tracheal ring. This is called the mid tracheostomy. We leave the first ring to prevent damage to larynx. Once again, most common site of tracheostomy is second and third tracheal ring. We do not touch the first ring to prevent damage to larynx. But next page, high tracheostomy. Next page, high tracheostomy. What is high tracheostomy? It is done in cancer larynx. It is done at first and second tracheal ring. It is done at first and second tracheal ring. Everybody, please see. Now, few questions. Tracheostomy can lead to apnea due to CO2 washout. Tracheostomy can lead to apnea due to carbon dioxide washout. What is the most common complaint tracheostomy? Hemorrhage. Tracheostomy can lead to hemorrhage most commonly. Why tracheostomy causes apnea due to CO2 washout? Now, next one is what is surgical emphysema? It is collection of air below the skin. What is surgical emphysema? It's collection of air below skin. Anybody, what is the cause of surgical emphysema? Tight skin sutures. Surgical emphysema means collection of air below the skin. The cause of this is the tight skin sutures over there. Okay. What is the best tracheostomy tube? Portex PVC cuffed tracheostomy tube. What is the best tracheostomy tube? Portex PVC cuffed tracheostomy tube, because cuff decreases aspiration. Very, very important. This picture is important. Portex PVC cuff tracheostomy tube, because cuff decreases aspiration. Now, finally, if tube is blocked due to improper suction, it's an airway emergency. In this case, remove the tube immediately to put the new tube. Remove the tube immediately to put the new tube. Once again, please see, best tracheostomy tube for ICU patient or in general is Portex PVC cuffed tracheostomy tube, because cuff decreases aspiration. Now, then indication are for airway management in problem above the level of trachea. Number two, for prolonged ICU stay on ventilator more than 7 days. For bronchial toilet, be cleaning of lung in COPD patient in coma. To prevent the aspiration, cuff or to prevent aspiration, and maxillofacial trauma is the PYQ. Give double advantage of the aspiration of blood, also prevention, and the maintained airway also. What is the commonest site of tracheostomy? Second and third tracheal ring. We leave the first ring to prevent damage to larynx. High tracheostomy is done for cancer larynx. It is done at first and second tracheal ring. Tracheostomy can lead to apnea due to CO2 washout. Most common tracheostomy is the hemorrhage. What is surgical emphysema? Collection of air below air in the subcutaneous plane. The cause of this is tight skin suture around the tracheostomy site. Okay, this is the best tracheostomy tube for exhibition, PVC Portex cuff tracheostomy tube. If tube is blocked due to improper suction, then we can remove the tube immediately to prevent aspiration. Fine. Guys, we have come to the final segment of this thing is the airway foreign body. Anything left now? About the three foreign body we're going: laryngeal, bronchial, tracheal. All of you are advised. Tell me anything which we have not revised in this topic, larynx. Anything? Have you touched about why I kept foreign body last? Very, very important topic. But why I kept foreign body last? We're fine. All good. I hope you have seen that in the span of 6 hours only, we have been able to touch upon a lot of part of the notes. I don't know what is your feeling. I don't know what is your feeling, but for my feeling is right now that in these 6 hours together, we have been able to touch upon the lot of critical, important, areas of our notes, more or less a lot of areas, I would say we have been able to see those things. And now if you revise one more time together and you are able to do 100 questions in the test, and then attend a discussion of those 100 questions also, I think it should be really making some sense of some like something. Why, for example, but only thing is when you do MCQs, so now for any subject, like for example ENT, now 100 question will be there. You should not really be in a hurry to answer. Read it and then like properly think and answer it. Don't say, oh wow, this question is there. Like just don't imagine it like that, na? So that is the one thing we need to now start working upon, and this would definitely help us get better score actually. Now, let us do the laryngeal foreign. Three foreign bodies are laryngeal, bronchial, tracheal. Laryngeal, bronchial, tracheal foreign body. Laryngeal, bronchial, tracheal foreign body. Laryngeal, bronchial, tracheal. Everybody, if tube is blocked to improper suction, what would you do? What would you do? Remove tube immediately. Why? Because It is airway emergency. Yes. In this case, SpO2 is falling. The Portex PVC cuff tracheostomy tube. This one, no? Fine. Cuff decrease aspiration. Tight skin sutures. I'm just filling the PDF, which the final PDF, no? Yeah. Now, laryngeal foreign body mean patient get choking and aphonia. The keyword are choking and aphonia while eating. It due to food particles stuck as laryngeal foreign body, airway emergency, immediately hemorrhage maneuver. Whenever you see the patient of the laryngeal foreign body patient should go for the hemorrhage maneuver. In hemorrhage maneuver, the pressure is given on the epigastrium in backward and upward direction. Pressure given on the epigastrium. This is a visual question also. This is a very likely question. Hemorrhage maneuver, foreign body airway is a very, very commonly thing asked. Fine. And then in this case, we push the pressure backward and upward direction, backward and upward direction. And this is the place we put the pressure. But in a child, 2 year or below that, we give back slap. Back slap. In a child below 2 years or up to 2 years, we give back slaps. But one question came in last paper was child has laryngeal foreign body, choking aphonia, but unresponsive child. My dear friend, the patient was having choking and aphonia, but unresponsive child means no child probably yes, chest compression should be done, the CPR. In this case, you do the chest compressions. So if it is a child with laryngeal foreign body, back slap. But if the child with laryngeal foreign body has turned unresponsive child, then you do the chest compression in that. CPR, yes. Let's revise the bronchial foreign body. Bronchial foreign body is seen in 0 to 4 year of age. Right is more common than left side because right bronchus is wider and more in line with trachea. It can be vegetable foreign body, metallic foreign body, and plastic foreign body. But the vegetable is the commonest foreign body. Out of vegetable, peanut is the commonest foreign body. Peanut is the most common foreign body. Once again, why right bronchial foreign body are more common than left side? Because right bronchus is wider and more in line with trachea. Then, what is the commonest foreign body? Peanut. What is the age? 0 to 4 years. Now, what is the clinical picture? A child with sudden cough and breathing difficulty. Child with sudden cough and breathing difficulty. Sudden cough and breathing difficulty. While playing, no history of any prior problem. Child has sudden cough and breathing difficulty. Okay. That is the case. Investigation X-ray chest. So, as X-ray chest to be done. Now, X-ray can show collapse. Like this X-ray shows collapse. The upper part of the right lung got collapse. X-ray shows collapse. Number two, hyperinflation. It can be hyperinflation. Why? Because of air, the foreign body of this shape that it allow the air to go in the lung, but not allow the air to come out of the lung. If the circular foreign body, it is like a valve kind of mechanism. The foreign body allows the air to go in, but not allow the air to come out, hyperinflation. Or sometimes it can be just a normal X-ray also, because patient may have come very fast to the emergency. Normal X-ray also. Okay, fine. So collapse, hyperinflation, normal X-ray. Treatment is what? Treatment is surgery. Which surgery? Urgent, rigid bronchoscopy and removal. Urgent, rigid bronchoscopy and removal. Urgent, rigid bronchoscopy and removal. Okay, let's revise once again. The bronchial foreign body are seen in 0 to 4 year of age. Right side bronchial foreign body are more on the left side because right bronchus is wider and more in line with trachea. And the foreign bodies, bronchus can be vegetable, metallic or plastic, but vegetable are the commonest. Out of vegetable, peanut is the commonest foreign body. Generally, patient has got no history. Suddenly, cough and breathing difficulty start and get an X-ray chest done. You can't see foreign body mostly because foreign body is radiolucent, like peanut, but you can see collapse, hyperinflation, or it can be normal X-ray also. Treatment is urgent rigid bronchoscopy and removal. Now, tracheal foreign body. Tracheal foreign body is having two characteristic words. Number one, palpatory thud. If you keep your finger in the front end of the neck, you can feel the upward downward movement of the foreign body in the tracheal air column. It's called palpatory thud. THUD. Palpatory thud and audible snap. Palpatory thud and audible snap. Palpatory thud and audible snap. So look at me. If you keep your finger over here, you can feel the movement of our body in the trachea, palpatory third. You put a stethoscope over here, you can hear that movement also, audible snap. Okay, it's serious and the treatment is same. The treatment is same as bronchial, urgent, rigid bronchoscopy and removal. Because all three foreign body have got unique word. Laryngeal foreign body word is choking and aphonia. The bronchial foreign body is sudden cough and breathing difficulty in a child. And tracheal foreign body, the characteristic word is palpatory thud and audible snap. Palpatory thud and audible snap. Palpatory thud and audible snap. Now I invite everyone, any topic in your mind which you think we should have done. Okay, any topic, anybody, anybody? Can you tell me anything? All okay? R&D, because I was told R&D they cover in the series, but we're going to cover R&D, no problem. Radical neck dissection, everybody. Radical neck dissection, what is that? We remove multiple structure from the neck. Let's open up your R&D page. The radical neck dissection is number one, we remove the level 1 to level 5 neck nodes. Number two, the sternocleidomastoid muscle, internal jugular vein, excessive spinal nerve, omohyoid muscle, and tail of parotid and submendular salivary gland. Once again, R&D to clear the cancer of the neck node, what all we remove? Number one, level 1 to level 5 neck nodes. We remove two muscles, sternocleidomastoid and omohyoid. We remove which vein? Internal jugular vein. We remove which nerve? Excessive spinal nerve. And finally, two salivary gland, tail of parotid and submandibular salivary gland. What is modified R&D? Modified R&D is when you do R&D, but few structures are preserved. In modified R&D type 1, you preserve the accessory spinal nerve. In type 2, you preserve the accessory spinal nerve and internal jugular vein. In type 3, you preserve the accessory spinal nerve, internal jugular vein, and sternocleidomastoid muscle. So in modified R&D type 1, you preserve one structure, excessive spinal nerve. In type 2, you preserve two structures, the excessive nerve plus interjugular vein. In type 3, you preserve excessive spinal nerve, interjugular vein, and sternocleidomastoid muscle. Sternocleidomastoid muscle. Anybody, any questions? I hope you have got this thing in your mind very clear that these remaining days are very crucial for your examination, and I hope you are absolutely clear about it. That if I'm afraid of the result, if I'm forgetting and all that, all those kind of negative thoughts, etc., will not have any value when the examiner is going to put the questions over there. Examiner is going to just put the question. We feeling negative, feeling low, has no emotional value on that day. On that day, we are not assessed on the emotional quotient, we are assessed on the intelligence quotient actually. So last 28 days, if you revise the content more appropriately, I'm not saying everything you'll be recalling, but you'll be recalling a lot better than what you're doing currently. So that actually, the most important thing is that you must really, spend all these remaining days in a proper way. Fine, fine, all okay, fine. I think we have been able to. No topic is left now. Okay, fine. I think that's so. This is what I had planned for the this thing. I'll be sharing this PDF with you. You can keep the PDF with for the final revision. But for this test and discussion, please refer to the main notes. But I think for the final revision before the exam, we have got a lot of stuff over here for that thing. Okay, fine. Thank you very much, everybody. Thank you, everybody. Thank you, everybody who is joining. Some I can just read the messages of the online live people only. But definitely, best wishes from my side. Not for the exam. We'll come. We'll definitely connect again before that. Best wishes for wonderful revision. Best wishes that you keep yourself pulled up to the positive side at your story. Nobody can be positive ever forever. Try to remain positive. Don't try to be positive. Don't be positive is not possible. You can't be positive forever. We have to learn the art of remaining positive every morning again and again and again. This is something we forget every night. Every morning when you get up, you have to remind yourself the art and the skill to remain positive in that day. Unfortunately, we forget it every night when you sleep. Your brain get back to the same mode again, unfortunately. Okay, fine. Yeah. I'll send a PDF to the team only, and then they will send it to after screening. They'll send it to you guys. Okay, fine. Thank you very much, guys. All the best, and see you soon for the test and discussion after after a couple of days. I'll keep it after a couple of days. We get more, like more value at that time. Okay, fine. Thank you very much once again. Thank you. Any question anyone has? Anyone, any question, any doubt about your exam preparation? Yes. Any exam doubt about your exam preparation or anything you want to ask? What to do about any preparatory or any issues you are facing right now? Feel free. You can just let us know. But keep in mind that with the kind of like knowledge you have now, if you layer it up with good revision in the last couple of days, definitely lot of data will be recalled. Not whole of data, but lot of data will be recalled. Part one, no, but part one is like anatomy, physiology, biochemistry, pharma. Mike, I know it's like that, but then always split the day into two parts. You can revise. If, for example, Mike, pharma is challenging for you, for example. Then every day morning you do pharma, pharma, pharma. 1 hour pharma, 1 hour pharma every day. After 10 days, you change it to micro. Okay. Like two subjects can do 1 hour every morning. Like that. At least before the last 7, 8 days come in, still you have two prominent subject. You keep 1 hour every day. 10 days, 1 hour revise the main point of that. Okay. Chal. I think all good. Okay. I'll take your leave now. All the best, guys.